Good morning, everybody. We will call the meeting of the Standing Committee on Homelessness to order at 8:37. And could I have a roll call from our city clerk?
The record should reflect the chair and vice chair are both present.
Please rise for the Pledge of Allegiance. Ready, begin. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. To speak on an item on the agenda, please fill out a speaker slip with the number of the item you wish to speak on. Speaker slips are available outside of the council chambers. If you are participating via Zoom, please raise your hand or press 9. We will indicate when you are, it is your time to speak. Speakers will have 3 minutes. Our first order of business is the approval of the August 22 meeting minutes. I don't have any changes to the minutes. Do you, Mayor?
I do not.
All right, then we will move forward with the approval of those minutes by unanimous consent. Next, with oral communications, do we have any speakers this morning?
No speakers.
Great. So let's move on to our first discussion item, an overview of SB 43 and local implementation. Again, if any members of the public are joining us, please raise your hand or press 9 on Zoom. Mike Phillips, Senior Director of Patient Advocacy and Housing Services, will provide the presentation. Thank you for being here this morning.
Thank you. Thank you. Good morning. And I also have Mariel Horner with me. Mariel, you want to be over here? Okay. We're going to co-present if that's okay. So I want to introduce myself. My name is Mike Phillips. I am the Senior Director of Patient Advocacy and Housing Services with Jewish Family Service of San Diego. We have a lot of different programs at Jewish Family Service San Diego, one of which, of course, is the Safe Parking Program, and we're super excited and thankful for that partnership. Today, we're going to be wearing a different hat. We also have another program called the Patient Advocacy Program, and the responsibility of that, it's a state law mandated program where each county has to have a patient advocate to make sure that people who are receiving behavioral health services, either in inpatient psychiatric settings or drug and alcohol settings, or all kinds of mental health settings throughout the community, are being treated with dignity and respect, that the facilities are following the rules they're supposed to follow, and that if anyone believes that their care is not appropriate, they can reach out to us, family members can reach out to us, et cetera. And so one last thing before Mariel introduces herself is our role today and through the contract with Behavioral Health Services is to help educate and train about implementation. So that's why we're here to have this conversation. And this can be a 10-minute presentation or an hour long, depending on how many questions you have. So we welcome.
Yeah, feel free to kind of go over an overview, and I'm sure we'll have some good
Fantastic.
back and forth.
Meryl, do
Thank
you want to introduce yourself?
Of course. My name is Mariel Horner. I'm the patient rights advocate for the SB 43 initiative with Jewish Family Service.
Okay, so why don't we go ahead and get started? I think I have the clicker. Okay, so as I mentioned, we have a contract with the County of San Diego Behavioral Health Services through Jewish Family Services San Diego, and we were asked as part of the implementation of SB 43 to be part of the community education. I'm also the co-chair of implementation for San Diego County for this process. This is a law that was signed into a bill that was signed into law not too long ago by Governor Newsom, and the goal here from the Sacramento perspective is to address, even though it doesn't really call it out, to address the unhoused population and expand the net, if you will, of who can be detained pursuant to 5150. So we're going to talk about the current lay of the land as far as how 5150 and the mental health system works, and then we'll talk about the expansion that this would bring. And a lot of this has to do with legal definitions and sort of hopes and dreams of what this is going to look like. A lot of this is going to be what sort of resources are in the community to actually make this work, because there's a lot that still needs to be put into place, and funding is an issue as well. So we're going to talk about the bill as described, and then some of the issues that we're seeing. And this is something that's playing out across the entire state of California. This was a window of time that was given to each county in the state of California. They could start implementing January 1st, which is when Governor Newsom hoped everybody would start. At that time, it was only San Francisco and San Luis Obispo who started on that first possible date, and they've had some bumps getting started. And then the rest of the 56 counties are going to start sometime between last January and January 1st, 2026. Through Board of Supervisor, County Board of Supervisor approval, it was decided that San Diego County would implement right in the middle of that, which is this coming January. January 1st of 2025 is when the implementation is supposed to be all ready to go. Okay, I think we covered that slide. All right. So Mariel's going to talk a little bit about there's a whole LPS Act that exists and has existed for 57 years. This came out of the civil rights movement, and a lot of things obviously happened during that time. In the area of mental health, civil rights, this was when the big state hospitals were being closed down and individuals were being sent home. And in many cases, there were services waiting for them. In many cases, there were not. There was a lot of individuals that had lived their whole lives or most of their lives in those settings, and so that was their home. So this was a fundamental shift in the way the services were being provided. Part of it was a Civil Rights Act, but part of it was these buildings were getting old and they needed to be replaced and rebuilt, and that was a lot of money to be committed. So there's a lot of politics that was happening around why those facilities were closed. But that's when the LPS Act, or the Lanterman-Petrus Short Act, was signed into law in 1967, implemented in 1972. And the idea behind that was, if we're going to send everybody home and then bring them back when there's a crisis, what's that going to look like, and what's that mechanism going to be? How do we safeguard and maximize the individual civil rights of these individuals? But when danger is at play, danger is what allows us to infringe on individual civil rights. When danger comes in, then what are we going to do about that, and how's it going to look? And how are we going to maximize the dignity and respect of these individuals? Because for a lot of those state hospitals across the country, there was a lot of not very good care and very inhumane care. So Mariel's going to talk a little bit about the intent of the LPS Act.
Yes, so the LPS Act stands for Lanterman-Petrus Short. Like Mike said, it was fully placed into effect in 1972. It was signed into law by Ronald Reagan. So we like to always review just the basic principles of the intent of this act, just because it ties so deeply as well to the major changes that come with SB 43. So we just like to review it. So the purpose of the act and the legislative intent was to end inappropriate, indefinite, and involuntary commitment, to provide prompt evaluation and treatment, to guarantee and protect public safety, to safeguard individual rights through judicial review, and most importantly, one of the most important, we feel, is to provide individualized treatment, supervision, and placement. Like Mike said, there were so many individuals, suffering in the community without proper access to the necessary and appropriate mental health care. There were so many instances and documented cases of individuals going through this process not being treated with dignity and respect. More of the legislative intent of the LPS Act is to encourage full use of existing agencies and to prevent duplication of services, to protect persons with mental health disorders and developmental disabilities from criminal acts. I always like to touch on developmental disabilities, especially with this expansion of the definition of grave disability. So many individuals with developmental disabilities such as epilepsy, autism, cerebral palsy are oftentimes treated as gravely disabled, but a lot of times they just don't have access to the proper services, so that's always important to note. Also, to provide consistent standards for protection of personal rights of persons receiving services, and to provide services in the least restrictive settings appropriate to the needs of each person.
And I want to talk about voluntary for a minute. So politically, back in the 60s and the early 70s, the idea was to maximize the civil rights of these individuals. And some would argue that maybe those rights were maximized a little too much, although I'm a big civil rights person myself. And the pendulum now is swinging the other way, for right or for wrong. We're seeing now the idea that, well, we tried it that way and it didn't really work, so now we're getting a little bit more paternalism, again, for right or for wrong, in finding ways to bring people into care against their will if necessary. And so I really want to focus on the voluntary piece, because throughout all of the law and throughout Olmstead, which is a Supreme Court case which talks about people being able to receive services in the least restrictive setting, voluntary often gets lost. And especially when we start talking about the expansion into the SUD and drug and alcohol component, most of the data and literature and knowledge around drug and alcohol and SUD treatment is that it's most effective when someone, in that very small window, when someone's ready to receive care. And so what this would do, in theory, is detain people involuntarily and bring them to places, which is a little bit against the way that it's normally done, but also to places that we'll talk about in a little bit that are maybe not even capable of providing that level of care, and that some of the reimbursement models don't even currently exist to provide that level of care if and when the individuals are brought there. So I want to just remind everyone that the law mandates voluntary for whenever possible treatment. And the way that's defined is a person that is willing and able to receive voluntary treatment. And willing is basically you know where you are and you know what's going on. Willing is you want to, and able is you understand the process. One of the first hearings, my team, goes into psychiatric hospitals when people are detained pursuant to 5150. When that 5150 expires, they can be placed on a 5250 or a 14-day hold, at which a due process mechanism kicks in during the first 4 days. So my team, per state law, goes in, meets with these individuals and says, do you want to stay here, get some treatment? Do you want to leave? And then depending on what they want, we will then go into the hearing and have a conversation, and then a hearing officer will decide, after listening to the hospital and clinicians, does this person need to stay in the hospital or should they leave? About 90% of the time that person is held and detained. This is basically a check on the system to make sure that people are not being detained inappropriately, and sometimes people are just doing better 5 or 6 or 7 days later. I bring that up because one of the first hearings I ever did when I started this job was I met with an older gentleman at Scripps Mercy Hospital, and I said, do you want to be here and receive services? And he said, absolutely. This is one of the best submarines I've ever been on. So I realized the willing was there, but the able was not. So, and that's an important component. We don't want people to be receiving services if they don't understand what's going on. So again, voluntary is something that needs to be advised to individuals, and clinicians will almost always say that their treatment goes better and more smoothly when that person is a willing participant. We know that many times bringing people in against their will is what has to happen. There's a dangerous element that's at play. But if that person has a negative experience, there's a good chance that they will be unwilling to come back later on. Now, they may have to come back again involuntarily, but the former administrator of County Psych Hospital down on Rosecrans used to say that he defined a successful hospitalization as one in which a person was likely to return willingly if they needed help. And so we need to remember that these hospitalizations can be very traumatic. A lot of times people are being placed in handcuffs in the back of a patrol car in front of their neighbors, taken into the hospital, given strong medication against their will. So just keeping that all in mind as we talk about the new evolution and where we're heading. So I think that's all I wanted to say about voluntary. Did you want to add anything?
No.
Okay. I think you're up.
Okay. So as it stands today, and this will not be changing, the basic criteria to detain someone on an involuntary hold pursuant to Section 5150 is danger to self, danger to others, and grave disability. Today, we'll focus, of course, on the expansion of grave disability, but we always want to note how important individuals struggle in the community with suicidality and homicidality linked to behavioral health symptoms.
And I want to refresh again this idea that it was decided when LPS was being written that what would be the criteria that would be worth infringing on the civil rights to get involved. And so danger to self, you're doing potential harm to yourself, danger to others. These actually, the first two actually have no legal definition. You may hear urban legend around it means an imminent threat, it means an identified individual. That's not necessarily the case. It's really the judgment of whoever's initiating the 5150, and we'll talk more about that because maybe that's law enforcement, maybe that's a clinician in the LPS facility, maybe it's an emergency room that's not LPS. And I should define LPS versus non-LPS because I don't want to make sure everyone's on the same page. So LPS facilities means a facility that is capable of providing inpatient psychiatric care. And they're not allowed to do that in any county unless they reach out to the county and say, we want the ability to be LPS designated, which means they then have all these rules that they have to follow because of the LPS Act. If you don't have any capability or inpatient beds, then you probably should not be an LPS facility. And so facilities like, say, Scripps Encinitas, for example, is an example of a non-LPS facility, but other places like up until recently Palomar and not too long ago Tri-City, these are facilities that were LPS designated. When someone's detained pursuant to 5150, the goal is they really should be taken to an LPS facility because that's where the treatment is waiting for them that they're supposed to be receiving. But we also know that many times law enforcement will bring individuals to all kinds of different places, either because they know who will accept the patient, or maybe there's an emergency where someone's bleeding out and they say, we understand this is a psych issue, but we need to get them to the closest emergency room. Did you have a question, Mr. Mayor?
Yeah, so we have, we have 85 beds at County Mental Health at Rosecrans,
I think that's right.
and then we have 16 coming online at Tri-City.
That's right, with the PUF, the
Was
public.
it 120 at Palomar that are being built?
That's right. That's a new facility that's being built.
So what other resources, what other LPS designated, not that, I'm asking you for an exhaustive list off the top of your head, but
Sure.
particularly in this part of the county, but and actually I guess it's relevant countywide because there aren't enough of these resources that it's just in our region of the county.
You're exactly right. You're exactly right. And we'll talk a little bit about Palomar giving up its LPS designation and why. You may already be totally aware. Tri-City, why it gave up its designation. It'll be bringing, you're exactly right, that 16-bed PUF, it's called, Psychiatric Health Facility, online. And it's unclear at this time whether or not the LPS designation will extend to the entire hospital, as it used to when they were designated in the past. But, and I probably could give you an exhaustive list. So over in Poway, we've got Aurora Behavioral Health. And then more central, we've got UCSD Hillcrest.
How many beds do they have at Aurora, roughly?
That's a good question. We can get all those numbers for you. We've got them all. There were roughly, there were exactly 790 beds a few years ago throughout the county. And that counts even the beds that were available in Central Jail and the beds that were available at Las Colinas, because those psychiatric units are also LPS designated, which is uncharacteristic throughout the state. We have LPS designation in our jails.
If that's not an extreme hardship, I'd love to have a list.
Oh, no, totally get it. No, in fact, it's probably on our website already. So if it's not, we'll absolutely get it to you.
Great.
Yeah, so we've got Aurora and Poway. More centrally, we've got UCSD Hillcrest. We've got County Psych over at Rosecrans. We've got Scripps Mercy. Over in the east, we've got Alvarado Parkway Institute, formerly Alvarado Hospital, which is now UCSD East. We've got in the south, Bayview Hospital. We've got Paradise Valley Hospital. In the east, we've also got Sharp Grossmont Hospital, centrally located Sharp Mesa Vista Hospital. What am I missing?
No, that's great. So you think that's on the CMH website or on JFS?
Well, it's on the, it may be on theirs, but it should be, all the facilities are on the JFS website, but I'll get you a full bed count as well.
Okay, I appreciate that. That'd be very helpful.
And why it's relevant is that the non-LPS facilities really struggle when they end up getting individuals pursuant to 5150, because then they're not prepared to treat. And then they've got to find a way to get those individuals into the very rarely open beds in the rest of the system. And so people get stuck in the emergency room. There was a new law that went into effect about a year and a half ago, bill called AB 2275, which said we need to start, and our team is doing these, due process hearings in the non-LPS facilities, because those individuals are not only in the wrong place, but they don't have any access to due process. And that's really awkward because those providers are not trying to detain people against their will. They're trying to move people along, but they can't, either because the beds are not available or because those individuals have very complicated clinical pictures which makes it very difficult to figure out where individuals can go. A lot of our services are sort of, this is for mental health, this is for developmental disability, this is for SUD. What happens when you've got someone with all of the co-occurring things? So that individual becomes harder to place, and they end up staying a very long time in an emergency room. We've all spent time in an emergency room. It's uncomfortable if you've even been there a few hours. We're talking about people being stuck there for days and days. Across the country, we've seen 39 days in certain emergency rooms. I think in Georgia, there's a record of like 3 months. Can you imagine being psychiatrically detained for 3 months in an emergency room? So just a little bit about sort of where everything is jammed up. Okay, so these 3 criteria, the first 2 are not defined. Grave disability is defined, and we're going to go over the current definition, and then we're going to go over the new one.
You're saying that they were held in those emergency rooms without any kind of due process?
Likely, yeah. Mostly I'm speaking to the length of their stays,
Right.
and up until recently, there has been no due process in the non-LPS facilities. There's a lot of due process built into the LPS process, but not in the non-LPS process.
So they can strap you to a bed in the ER and hold you there as long as they want?
Yeah, arguably, yes. Legally, they cannot. So in California, we've got 5150. It's different in each state. After the 72 hours 5150 runs out, that person is technically free to go. And hospitals then have this uncomfortable decision to make. Do we, through a non-legal process, keep this person here because we're so worried about them, or we're worried about the bad outcome, or we're worried about the headline, or whatever else would come, that they end up keeping people there past the 5150, 72 hours, just because they're afraid of all the terrible things that can happen. And so that's why this AB 2275 bill went into place. There's an awareness that this is occurring. Can we at least bring in the due process? But what it doesn't do is it didn't bring in any new resources or any new funding to then maybe help move people along. What good is due process if we don't have any ability to move people along?
Which one was 2775?
So AB 2275 was the one that basically said, if you're not LPS designated and somebody is brought to you pursuant to 5150 and that 72 hours runs out, you are without legal basis to detain the person, and then within the next 4 days, a hearing will occur. And in that hearing, it's basically a determination of whether the burden of proof is met, which we'll talk in a second about. Is there enough evidence to say that this person is still danger to self, danger to others, or grave disability? But then after that, the hearing officers leave, my team leaves, and this hospital's left with all the same struggles they had trying to get the person placed.
But even then, there's a facilities issue that you're describing, right, where we have a lack of LPS facilities that can
Right,
accommodate
which
that.
is why they're jammed up there in the first place, because there's no beds. Although, to maybe go back to a 10,000-foot level, I would argue, and I think many others would argue, that do we need more inpatient beds, or do we need more lower levels of care before inpatient hospitalization and step down after inpatient hospitalization, and a wide variety of those services, because one size doesn't fit all? And are they accessible? Are they affordable? We tend to treat medical issues so differently than psychiatric. If you've got a medical issue, you go to your outpatient doctor, handle things. In the psychiatric world, we tend to wait until someone is in an acute crisis and then put them in a police car in handcuffs, take them to a psychiatric facility, maybe medicate them against their will, exacerbating traumas, especially if someone is already dealing with traumas or has that in their background and history. And then we spend 3 to 5 to 7 days providing some medication, and then we discharge them to something that may not be nearby where this person lives. They may not have transportation. It may be 30 days, their next appointment. So those linkages before and after, I think our default is there's not enough beds. We need more beds. But I've even spoke to the administrators of psychiatric facilities who said, if we had better services throughout the community, maybe the psychiatric hospital, doesn't need to exist at all. So it's just another way to look at that, is are we providing those services instead of waiting until a crisis? And that's the most expensive level of care, the emergency rooms and the inpatient beds.
So what are those services that need to be provided in the county?
So essentially, if any type of mental health treatment, and Mariel has a clinical background, so I'll give her a chance to weigh in, but essentially, do I want to go to a therapist? Do I want to go to group therapy, talk therapy? There's all different kinds of therapy, and trying to create one version and have it apply to everyone, you'll get people who say, well, that doesn't work for me, so I don't want that. So Mariel, do you want to speak to like the kinds of services that would maybe take the pressure off of inpatient?
Absolutely. So, for example, if an individual is diagnosed with a developmental disability, such as cerebral palsy, Down syndrome, autism, epilepsy, they should be linked to their regional center. We go to hospitals frequently and we see individuals not being connected to or accessing services to their local regional center, and A lot of times those individuals end up in the cycle of involuntary hospitalization because they struggle very deeply to communicate their needs, or a lot of them have family members who care for them and support them, or some of them just fall under the radar of receiving mental health care. I've had the honor and privilege to serve youth, children, and families across San Diego County from Poway down to South Bay. I've witnessed how effective outpatient therapy can be, trauma-focused therapy, expressive arts therapy. Children endured a lot of trauma during the COVID pandemic. They lost a lot of access to socializing and broadening their horizons. So a lot of the individuals, when I was working at Rady Children's Hospital, I saw the direct impact of that. And most of that was just that their parents couldn't get them services, long wait lists. So the county is consistently trying to address that by vendorizing more mental health providers across the county, which can be very beneficial. Also, adults highly benefit from intensive outpatient programs. We have quite a few reputable ones in the county, Sharp Mesa Vista, several programs. So that's probably one of the most reputable programs across the county for providing different access to care, such as a track for veterans, a track for postpartum individuals struggling with postpartum depression. So there's a long, exhaustive list. And during this training initiative for SB 43, we took it upon ourselves as a team to go through the 211 list for every single provider across the county that would be relevant for this education for SB 43. And we're really reaching a wide audience from law enforcement to LPS facilities, non-LPS facilities. Yesterday, we were able to reach Southern Indian Health Council, which is a very underserved community, as we all know, across the county. And there's an exhaustive list, but those are just some examples of things that we as a county could really benefit from the promotion of and better connection to services. And that's something that we help to support through our program at Patient Advocacy.
I appreciate being able to have this discussion as part of the entire item, because I've recently witnessed my neighbor go through a mental health crisis, and the way that he descended into crisis, there may have been opportunities for him to have more support earlier on that could have helped, right? But I don't know how easily it was for him to access that, and how affordable it was. I think that there's a lot of barriers, including just that there's not enough services widespread for people to access. So I appreciate you bringing up that point, because I think we do talk about high acuity individuals a lot, but they have to get to that point typically. So I appreciate that. Before they get to a point of grave disability, which we'll be talking about next.
And I'll add to that engagement is a huge piece. So a few years back, I guess it's been 10 years ago now, before Laura's Law was being implemented across the county, there was a team that was created called IHOT, the In-Home Outreach Team. And the goal of this team was to essentially, and it still exists, the goal of this team was to take someone who is a family member, someone who's a peer, someone who's a clinician, and then when individuals are identified as possibly needing care, perhaps your neighbor at an earlier stage, this team goes out and it starts building engagement. Hey, we're here to help. Do you want to maybe think about some services? And it sometimes can take several months to build that engagement and build that trust, but they have been very effective over time in building that trust and getting people to then avail themselves of services. We also have to call out that there's a huge stigma around mental health and drug and alcohol, and so that creates a sense of shame and a sense of, I don't want to be going to the hospital because now I'm a crazy person. I don't want to stay on my medication because if I can wean myself off of it, maybe I'm not crazy anymore. So there's reasons, a lot of reasons why people wouldn't want to avail themselves of services. And some of it is, you'll hear the term, especially out of the NAMI programs, you'll hear this term anosognosia, which is technically a diagnosis, although you don't really see it in the hospitals. It's essentially lack of insight. This idea that someone is struggling with a mental health illness, but they are not aware of the fact, or to the extent that they're struggling, and that you've got to push through that to be able to get forward to get that person to access care. Also, I'm sure you're aware in the recent years, MCRT, the Mobile Crisis Response Teams that have been created, several based up here in North County. And then also PERT is another organization. PERT is 26 years old now. PERT was created 26 years ago when some negative interactions occurred between law enforcement and responding to individuals in their home settings. People died, people were injured. So PERT, what they did was, you maybe already know, they took a patrol individual in the car for safety purposes, and then a clinician partnering with them to not only to do a very nuanced assessment when they arrive, but to also de-escalate the situation, something that law enforcement typically doesn't know how to do. Law enforcement will often say, we were not trained about mental health. We didn't go into this job for mental health, and almost everything we're doing is some flavor of mental health or domestic violence. The PERT teams are amazing, and I will do a ride-along every few years. And watching that officer, they have basically become a clinician in that the way they approach individuals and the way they de-escalate, it's absolutely beautiful. Now, you have to self-select into that role as law enforcement, and a lot of individuals are not interested, but you absolutely can create that team where those two are working together in tandem. PERT, there's crisis intervention teams across the state of California. PERT is ours, and PERT is really the gold standard. So if you don't already know more about PERT, I'm sure you can get connected up. If not, we can help make those linkages too. I wanted to talk about the burden of proof. So when someone is being detained pursuant to danger to self, danger to others, or grave disability, there needs to be a burden of proof attached to it, meaning how much proof do you have to do a thing? And you'll see this in court cases when someone's making their case as to whether someone's guilty, not guilty, civilly liable or not. There needs to be a certain amount of evidence that needs to be met, a threshold. And I'll do my 30-second law school class here on burdens of proof. So if this is zero amount of proof and this is 100%, you've got reasonable suspicion down here. You've got probable cause, which is where we're going to be for most of this conversation today, very low still. Preponderance of the evidence, which is close to the 50% mark. Clear and convincing, around 75%. And then beyond a reasonable doubt, which is really, really high. My point is this definition, when I won't read it because it's kind of wordy, but it basically, you need to have articulable facts that would indicate a reasonable person to believe that there's some crisis going on here that likely would need some intervention by professionals. So you don't have to have very much. And so from a civil rights perspective, this feels really low. To detain someone, take them somewhere, lock them up, maybe they can't go home, feed their dog, go to work. The way that this is justified is that there's a bunch of due process mechanisms that kick in very early, and also that first detention is only 72 hours. The idea being that before the LPS Act, you had people that were just disappeared into psychiatric mental hospitals for the rest of their lives. Here, short term, which can then become a longer term. And if you want, I can also send the different holds that people can be placed on. We've got a really good graphic that we can share. 72 hours can lead to 14 days, can lead to another 30 days, and after a new law that went into effect this year, another 30 days. So even just in the last few years, we've gone from a maximum detention period of 17 days, that's the 72 hours plus 14, to now 77 days in San Diego County. That's a lot. A lot of this is justified or rationalized in a way that says we're trying to avoid putting people on conservatorship if we don't need to, but also conservatorship is going to be maximized as well under this new under the new political laws that are going into place now. That's really what SB 43 is really all about. It's an attempt to lower the threshold or broaden the net, if you will, for individuals that would qualify for long-term conservatorship. It also applies to all these other holds, but really that was the design, that people who are in need of help, can we put them on conservatorship and put them somewhere? And the question of somewhere is something that has to be answered as well. And really the answer to that, I think currently, is Proposition 1. Proposition 1, you're probably aware, but back in March, Proposition 1 was passed. I think only 7 million voters voted in that election, and Proposition 1 passed by a narrow margin, 20,000 votes. But what that does is two things. It creates $4.38 billion, which will be general obligation bonds used to design and build more treatment, more housing. About half of that is supposed to go to treatment facilities. About the other half is supposed to go to permanent supportive housing and similar types of housing. It also carves up the existing pot of money under the MHSA Act, probably aware of the Mental Health Services Act, which passed in 2004, 1% tax on millionaires, supposed to go to cover all the gaps that Medi-Cal wouldn't cover. That pot of money, which is roughly about $3.3 billion statewide out of the $12 billion behavioral health budget in total, is now going to be diverted. $1 billion of that's going to come off the top and go toward housing. And then what remains of that $3.3 billion, which changes every year depending on the taxes, will go towards a mix of, instead of just mental health, to mental health and substance use. So all good causes, mental health, substance use, and housing, but we're carving up that pot of money that used to all be devoted to mental health services. So we just need to be aware that those are dollars that are most likely committed to existing services. So as we divert to these things, just something to be aware of. So the where will people go will most likely be answered by Prop 1. How long is that going to take, and what kinds of facilities, and who will have access geographically? That all remains to be seen. That's all being decided right now. Okay, so that's the burden of proof. And then, Mariel, I'll hand it to you.
Okay, so enter SB 43. SB 43 significantly expands the definition of grave disability. It now includes substance use disorder as an allowable category for someone to be compelled into involuntary treatment or be placed under conservatorship. Like Mike mentioned before, San Diego County will be implementing this by January 1st, 2025. It also introduces another aspect to the definition, which are personal safety and necessary medical care. We will break down the definitions that we have and kind of provide some examples that will make it a little more sensible besides just the basic things that we first think about when we think of personal safety and necessary medical care. And clinically, the number of individuals, it says here, could dramatically increase, but as we're speaking to mental health providers and talking to different facilities, LPS and non-LPS, and just having that personalized clinical experience, this will deeply impact the number of referrals that will be going to local mental health providers, whether that treatment option is within the hospital setting or without. We've also been discussing how SB 43 will impact the payer Medi-Cal and Optum. So these are things that are developing as we go. And when we first approached this, when I came onto the team and Mike and I discussed how we would approach the training, especially for facilities and different mental health providers, we felt that at first we would kind of walk in with a limited clinical scope, but as a clinician and just as a team, as we keep getting very interesting questions as to how this will impact them, whether it be from clinicians, physicians, different people who work in the hospital setting and outside. We're getting a lot of questions about how this substance use disorder entrance is really going to impact them, and most importantly, the clients that they serve.
And I'll add, I think that number, the dot point on the upper right, that's the one that's got everybody nervous, is how many more individuals is some people are saying we want it to affect a lot more individuals. And the systems that already exist, that are already overtaxed and under-resourced, are saying we can barely handle what we're dealing with now. So it's really going to be interesting to see how many more individuals this applies to. Disability Rights California predicted a 10-fold increase on the number of people detained. That's a lot. The only things that we have to go by right now are San Francisco and San Luis Obispo, because they started on January 1st. The numbers coming out of those two counties are not super informative yet to get a sense of what we might see in San Diego. They estimated of the people being placed on the new definition of grave disability in San Luis Obispo that 12% of those that were detained under the new definition. Does that mean that that's a 12% increase, or is that someone that was already dealing with co-occurring disorders in the past that just now has a different box that can be checked when you're putting somebody on a hold? That remains to be seen. So some doctors have said, I already have these patients in my emergency room. They're already here. And others are waiting for the dam to break or the tsunami to come. So that's what we're trying to get a sense of what's waiting for us. And we won't know until we get there. So we'll look at the previous definition. And the previous definition is that there needs to be a mental health nexus. And this is the definition for the last 57 years, right up until January 1st of this coming year. There needs to be a mental health nexus that because of a mental disorder, a person is not utilizing food, clothing, or shelter. This is a self-neglect concept. We're not talking today about danger to self, danger to others. Those will remain. Those have no definition at all. Those are not affected by this change. How much of this evidence needs to exist? That probable cause amount. So enough to make a reasonable person believe that whatever strange or dangerous behavior is happening out in the community, that we think it's because of mental health and it's affecting food, clothing, and shelter. Food, typically this presents in the due process hearings that we do and in the clinical settings, this is not, are you wearing an outfit that people think is strange, although sometimes clinicians will make that argument. Are you wearing no clothes? Are you wearing 10 layers of clothes in the heat? Although a lot of unhoused people wear their entire closet when they walk around, so sometimes that's out of necessity. Clothing, we don't get into the minutia of did you eat lunch today, because a lot of people probably aren't going to eat lunch today, but are you eating so little that you're grossly underweight? Are you feeling like food is poison and that's not why you're eating it? Are you eating strange objects that are not meant for consumption? Shelter, that one does not necessarily mean that you don't have housing. It really does need to be connected to that mental health diagnosis. So if someone is unhoused and it's not because of a mental health diagnosis, then that's usually not going to qualify as the definition. That's the existing definition of grave disability. And then the new one, if you look at the language that is not bolded and not underlined, that's that same old definition we just mentioned. That all remains. But added to that is a new nexus. In addition to mental health, we're adding severe substance use disorder. And that's important because for the last 57 years, there's been no mention of substance use at all in the LPS Act. It was a purely mental health act, which didn't really track reality because you don't have people just showing up with a mental health condition and nothing else. So, but it's important because the rest of LPS doesn't really address severe substance use. So this is a sort of a real dramatic change in the definition. By adding substance use, it can be mental health alone, it can be severe substance use alone, it could be both. And then adding to that food, that clothing, and shelter, and you can see why this is designed to address the unhoused population, is that the person is not able to provide for their own personal safety, which we're going to see a definition of in a moment, or that they're not availing themselves of necessary medical care. So this, again, is language that's designed to address everybody, really, but specifically the unhoused population. We're going to get into the definitions, and oftentimes legal definitions are not super useful in the actual real world, and so we'll talk about how we're working with law enforcement, where we're working with clinicians in other counties to help develop some examples of what type of observable behaviors might fit into these categories, because the legal definitions are wonky even for clinicians, but even more so when we're expecting law enforcement to be out on the street diagnosing mental health and diagnosing severe substance use. In our collaborative implementation sessions, when law enforcement says to me, Mike, I don't know anything about severe substance use, and I say, well, you've been having to detain people for mental health for the last 57 years, and you're not supposed to be experts on that either. I think the idea behind 5150 at the law enforcement level is no one's expected to be a clinician. They're out around looking for public safety, looking for issues that are happening in the community. If they feel like something is playing out that from their good faith, non-clinical perspective is meeting this definition, then their job is to detain them pursuant to 5150, take them to the professionals, the clinicians, who would then assess using these more nuanced definitions. Is this you or me?
Okay, so to our new definition, like we mentioned before, we're introducing severe substance use disorder. That means a diagnosed substance-related disorder that meets the diagnostic criterion of severe, which is defined in the DSM-5 TR, the Diagnostic and Statistical Manual of Mental Disorders. This is used by licensed clinicians and other healthcare providers. So to meet the threshold of severe substance use disorder, as it exists right now, and this will not change, the DSM-5 just changed about maybe 5 or 6 years ago, there's mild, moderate, and severe. So to meet the severe criterion, you need to meet 6 out of 11 symptoms for severe substance use disorder.
You can imagine that non-clinicians, bless you, that clinicians struggle with these assessments, but non-clinicians, law enforcement, I don't think we really want them to be diagnosing pursuant to the Diagnostic and Statistical Manual. It's hundreds of pages. It's 6 out of the 11 different criteria, most of which would not even be observable by someone who's just interacting with somebody in the community. So even though that is going to be the new definition, we're going to have some good faith efforts made by law enforcement. And as I said, law enforcement actually approached us and said, we want to work with you all to help develop hopefully standardizing consistent observable behaviors so every law enforcement agency isn't doing something totally different. So we're working with law enforcement on that now. Personal safety is very vague. This is the one that makes my civil rights heart cringe a little, in that certainly personal safety is important, but this is very broadly defined. The ability of one to survive safely in the community without involuntary detention or treatment pursuant to this part. Really, really vague. So we'll have to see how that's applied. And also there's an or, I don't think they mean it to be this way, but this suggests that if someone needs to be detained even without treatment, they could still be detained if they can't provide for their own physical safety. So we'll have to see how this one plays out. This one I wish was defined a little more specifically, but it's not.
The next aspect is necessary medical care. This means care that a licensed healthcare practitioner, while operating within the scope of their practice, determines that medical care is necessary to prevent serious deterioration of an existing physical condition that, if it's left untreated, it can be likely resulting in serious bodily injury. Some examples that we see in the community and in my work and many others is specifically pertaining to substance use. There are many intravenous drug users who seek help and they are experiencing cellulitis, abscesses, but a lot of times they're afraid to access care because of the fear of involuntary hospitalization or getting caught up in the system of lack of access to appropriate care, or just generally being misunderstood in the community due to the stigma surrounding substance use. Another example is if you're living with untreated diabetes, blood sugars 300, 400, we've seen that in the community, and either scared to access that care or due to mental health symptoms, you are just not accessing it. A lot of times in this community here in San Diego, there are individuals suffering with psychosis. They can hear voices to not take the insulin, not take the medicine, it's poison. And that can really affect, their physical condition. And in many cases, it has led to loss of life, loss of limbs, loss of just thriving in the community. So we just wanted to provide some examples for that.
Thank you for the further definitions. Pardon me. So it sounds like the definition hasn't just expanded with substance use disorder, but there's a few other elements included that will also impact mental health patients, right, who might not be suffering from a substance use disorder, but their mental health might cause them to neglect their necessary medical care. Exactly. Okay.
Yes,
Thank
it
you.
all has to go back to the nexus that we were referring to. So as of right now, for grave disability, there needs to be strictly a mental health diagnosis that's related to the DSM-5. And now we're introducing that substance use disorder, but realistically in practice, and even as you encounter people in the community, and as we're learning so much about trauma and how it impacts people with that mental health disorder, people turn to substance abuse, which makes it that co-occurring disorder. So more often than not, that is what the situation is.
So just to throw out some practical issues around this definition, it's a good definition, and all of the examples that Mariel gave are great in a clinical setting, but law enforcement is not, these are not observable things that someone in law enforcement is going to see, someone's diabetes or someone's blood sugar levels. In fact, one of our first implementation sessions where we brought a bunch of stakeholders to the table, including law enforcement, we created some vignettes that describe things like high blood pressure and things like that. And the law enforcement was like, with all due respect, that we were not going to know that. I don't even understand half of the medical terms you put up there. If I see somebody bleeding out or someone lying in the street with their head cracked open, then that I know is a medical condition. So part of that is going to be what exactly are we expecting law enforcement in the field to be able to see. Once they're in a clinical setting, then this makes a lot more sense, but not really until then. And then from another practical standpoint, I was presenting last week at a joint Sharp and Scripps Emergency Department collaborative, emergency departments from across the whole county. And EMS was there, fire was there, and they said, there's a very real chance that when 5150 is initiated by law enforcement in the field, and there appears to be a medical condition which may be actually very slight, maybe someone cutting, which is not a good thing, but certainly different than suicidality. If EMS is called, fire will respond, medical will respond. Medical will often then say, we've got to take this person to a facility to get treatment, and they will often start heading in a different direction away from an LPS designated facility to get medical clearance. So now we were using 5150, which is now going to be a psychiatric and SUD tool, to get them to the LPS facility, and potentially now that person is going in the opposite direction to a medical facility. Those medical non-LPS facilities are going to say, please don't bring them here. We are not LPS designated. Don't bring that patient here. So these are things that we just want to sort of anticipate, and EMS is at the table in these conversations, fire is at the table, law enforcement, but this could actually backfire and cause people to go to exactly the wrong place. So those are problems that have existed for decades. They likely will be exacerbated by this new definition. And as I mentioned earlier, I just want to say these are all of the different holds that this new definition would apply to. That last one, conservatorship, LPS conservatorship. LPS conservatorship is, in the past, been for mental health. It'll now be mental health and SUD. But that is designed for people who have maybe been hospitalized a bunch of times in a short amount of time, maybe 6 hospitalizations in a 6-month period. There's no exact number. The psychiatrist will petition and say, we think this person should be on a longer-term detention. The LPS conservatorship starts with a temporary conservatorship, which is 30 days, and if it has not, the issues have not resolved, that person can be placed on a 1-year-long LPS conservatorship, which is renewable every year. Some people spend 20 years, the rest of their life on conservatorship. Maybe you're at Alpine Special Treatment Center. Maybe you're in the Crestwood facilities. We've got Crestwood in Fallbrook, Crestwood in San Diego, Crestwood in Chula Vista. These are longer-term cares where people are on conservatorship will go to receive treatment for months, maybe years. They're supposed to be released from that conservatorship when they're doing better. Sometimes that happens, sometimes it doesn't. There are also a lot of people on LPS conservatorship that are placed in the community in boarding cares. There's adult residential facility boarding cares, and then there's RCFE's residential care for the elderly. These are places where it's a home-like setting, it's open, it's in the community. The idea being, can we have someone have as much freedom and be in a home-like setting, which is more conducive to recovery, but it's also not locked. And so that's if you need locked, then you're going to go to Alpine or you're going to go to Crestwood, at least in this county. And all these other detentions, so the 5150, new definition applies. This 5256 is that new hearing that 2275 created in the non-LPS facilities. The 14-day holds, the 30-day holds, this definition runs through all of them. We talking about minors? Okay, Is that me? All right. So minors, those of you that are interested, this one's a little tricky, but this question comes up to how does this apply to people who are detained that are minors? So the law previously has a whole different definition for someone being detained if they're a minor. And the definition of gravely disabled is completely different. And it's written here, it's very poetic. I imagine a law clerk wrote this. A minor who, as a result of a mental disorder, is unable to use the elements of life that are essential to health, safety, and development, including food, clothing, and shelter, even though provided to the minor by others. And so the idea here is that a minor is not expected to go out and provide for food, clothing, and shelter, but if those things are being provided for them and they're not availing, then we may have a problem if it's due to a mental disorder. And this calls out, I think this is important too, because everyone wants to use 5150 as this broad net, but intellectual disability, epilepsy, other developmental disabilities, alcoholism, that's going to change in a minute, other drug abuse or repeated antisocial behavior do not by themselves constitute a mental disorder. So it's really trying to focus on that mental health piece. Now the question of, is this definition going to change under the new SB 43? And awkwardly, and this is related to some recent case law about a conservatorship, this definition will not change, but this definition will only remain for the first 72 hours of detention. And then after that, if a minor is detained longer than that by any of those other tools, then the new definition will kick in. So this is very confusing in that the old definition, which really only speaks to mental health, can be used to detain minors, and then 72 hours later, it opens up to the more broad definition. So in practice, probably it'll all get blurred, and probably people with substance use disorders will likely be detained. But this will come up at hearings, due process hearings, and it'll be addressed at that point. So very confusing on that the old definition remains, but only for the first 72 hours. For adults, the new definition will start minute 1 and carry through all the holds.
Okay, we'll touch on weapons prohibitions, try not to make it too convoluted. So individuals detained pursuant to 5150 admitted to an LPS designated facility and placed on the 14-day hold pursuant to the new definition of grave disability, they'll be placed on a state Department of Justice weapons prohibition for 5 years from the exact date of the 14-day hold. Now this can be challenged in court. If they're detained pursuant to 5150, they're placed on a 14-day hold and then lose their automatic due process hearing, they're on a lifetime weapons prohibition ban that is from the Federal Department of Justice.
And we have a whole presentation on this for anyone who's interested. We can go deep into the weeds about all the different holds and all the different prohibitions that kick in. This is something that even a lot of clinicians are not aware of, and this is something that comes up. I do a lot of training for law enforcement, and they get nervous when they see this because someone who is in law enforcement in the military, security, likes to hunt, finds out that if they go seek mental health treatment voluntarily and suddenly end up on one of these involuntary holds, they may end up losing their rights for 5 years, for forever. Each year that goes by, each time there's a new terrible tragedy at a school, mass shooting, there's new laws that are added that will tighten this up and remove weapons even faster. And so that's just something that people need to know is happening in the background, because a lot of times I'll be speaking to kids at Rady Hospital. I'll have maybe a 13-year-old girl who says, I'm here voluntarily. I don't really want to be here, but I want to be a Marine someday. And I know that if I go involuntary, I'm going to end up on some gun prohibition and I'm done. So this a lot of times is, I think it's important for potential patients in the community to be aware that this can happen. And also some doctors will try to use 5150 to intentionally place people on weapons bans if they have concerns about that. There's also a Tarasoff piece. Tarasoff, you may already be familiar, is a 1970s case that basically, we used to be able to go to a clinician and a therapist, say anything we wanted to, and there was total protection. After the Tarasoff case, if the therapist believes that there is a harm that I am going to do to a specified individual or individuals, they are required to break confidentiality and reach out to law enforcement. That also triggers a 5-year weapons ban as well. So those are the weapons prohibitions. And then this is a key piece as far as the mechanism of how this is going to work. The law says people detained pursuant to 5150 can be taken and only really should be taken to designated facilities. And those are currently defined as psychiatric hospitals, medical hospitals with a psychiatric component, and crisis stabilization units. What it doesn't include is anything related to substance use or severe substance use. So with this current definition, if you detain someone after January 1st that is dealing with severe substance use, you're going to be taking them to a place that doesn't even provide that kind of care. And arguably that milieu could actually make that care even worse. And I wanted to mention earlier, and I'm remembering now, if you're detaining someone pursuant to necessary medical care and taking them even to an LPS designated facility, which is what you're supposed to do, a lot of the psychiatric hospitals are what's called freestanding, which means they provide psychiatric care and they do not provide any medical care. So if you detain me because I'm not taking care of my medical needs and take me to, say, Alvarado Parkway Hospital, which is LPS designated, they don't have any ability to provide that medical care. So these are things we need to take into account as well. Detain me for medical care, take me to the right place, which can't even provide that care. And then what happens next? Then we're maybe jamming up the works even more. There's a bill called SB 1238, which is a cleanup bill, as they call it. I believe it's by Talamantes Eggman, that would expand the definition of who can be LPS designated facilities. It would expand it to a lot of places that I think are not a really good idea, places like long-term care. For a minute there, skilled nursing facilities, crisis stabilization. Crisis stabilization is already on the list, but crisis houses. These are places that are not really prepared to receive people pursuant to 5150. The one good thing that does make sense is it refers to ASAM 3.7 and 4.0 level SUD facilities. These are facilities that are designed to treat severe substance use. The problem is that in the locked arena, these facilities don't even exist at all. We did a training yesterday with Sharp, and they were very proudly saying that they could provide substance use treatment to level 1, 2, and 3, and 4 ASAM criteria, but it's all purely voluntary. And as far as we know, there is nowhere in the state, the entire state, that would provide, that there's a facility that could provide involuntary locked SUD treatment. So again, if that's what we're committing to do here with this new definition, where are those individuals going to go? And as one of the officers said at our implementation meeting, he said, no offense, if you don't give me a new place to take somebody, I'm going to take them to the same old place I always have, which is the sobering center. So that's sort of the boots on the ground reality. We've got to build these new systems. There's already talk at the county level of trying to beef up drug and alcohol treatment at the crisis stabilization units. Part of this is going to be funding, because not only do the facilities not exist, but there aren't revenue streams and reimbursable ways to pay for this care. So those are all pieces that are going to have to be addressed. Designated facility broadens the net of who can be an LPS designated facility, but most facilities don't really want to be an LPS designated facility. Palomar just bailed out, and they were trying to find rates, reimbursement rates that would keep them from being in the red. They wanted to stay in the business, but it wasn't a good business for people to stay in. Tri-City, a few years before that, they were getting hit with possible multiple $million-dollar renovations that were going to have to occur after they had been assessed by JCO. It was too expensive. They were having a hard time keeping doctors employed and working in those facilities. So to create new categories of LPS facilities is one thing, but if the facilities are not motivated or incentivized or reimbursed to be LPS facilities, they're actually going to want to get out of this business, not stay in it. So I think that's an area that we need to advocate for as well.
As we just have a few more slides here, let's go over essential information in case we
got
have
it.
any questions at the
Yeah, and I think the rest of this is also extra parts that come along with SB 43, but not super probably what you want to talk about today. So we'll go through it.
This has been very informative.
Okay, we'll go through these quickly just to touch on them, and if there's interest, we can talk about it. So the next slide talks about who can initiate 5150s. Board of Supervisors have the ability and have already created additional categories and likely will create new categories of who can put people on 5150s. If you like, we will send you the current Board of Supervisors letter that says exactly who can initiate, because that's going to be a subject of discussion as who should be added to that list. These are the people that are currently on the list of who can initiate. But we'll send you the Board of Supervisors letter if you like it. Who needs additional training? All these parties. This I won't even go into. It's very much in the weeds. There's a new hearsay exception. I'll bring this up only because when someone wants to be put on, when someone's being put on a conservatorship, doctors have to go downtown. The patient has to go downtown. Doctors have to sit around all day. They're not able to go treat their patients, and they're not reimbursed. And it's the whole process of having to go downtown for doctors and patients is not ideal. This creates a new hearsay exception that would allow someone else to go downtown that still has awareness of the patient, but maybe is not the direct provider. It creates a new hearsay exception.
So they're not doing virtual appearances for stuff yet?
And that is something that the hospitals are desperately wanting to do. And I advocated for this as well because it's very inhumane to have patients be taken down. They're often strapped in gurneys out in the hallway, wait for long periods of time. If you're there all day, you're missing your meds. If you have hygiene needs, you're missing your hygiene opportunities to use the restroom and things like that. So this is something that hospitals are desperately advocating for. It would take a huge amount of pressure off the system. The courts in San Diego said it can't be done. As soon as the pandemic happened, we started doing it. As soon as the pandemic waned, they stopped again. So this is a really important area to advocate. The public defender would say these individuals deserve their day in court, which they do. So I've advocated for a pilot program where some people can go downtown if they really want to, but some people can just do it from the hospital. It's just better, or at least let the doctor beam in from the hospital. And then if the patient wants to be there in person, they can.
Why don't they use the conference room at Rosecrans to do these? They take the judge and the court reporter down there.
We were essentially doing that during the pandemic, but we are not doing it anymore. So there's politics and
That's the way it should work.
well, at least patients should be given the option.
And then you could stack them up schedule-wise and have 3 or 4, and then you can bring the patients from where they're being housed.
It's also unsafe to transport individuals because the laws of how to seclude and restrain people during transport once you leave the hospital are very gray, and people get injured. People get injured trying to escape. Staff gets injured. People AWOL from downtown, they just run away. So I'm all about the nobility of the individual being able to be in the courtroom, but there's so many negatives that go along with it. So that's a real sticking point in the community, particularly for the hospitals.
Yeah, they should bring the courtroom to the
And
hospital.
they can, and in other counties they're doing it. San Diego's usually very progressive, but in this area we have, I think, fallen behind. After COVID, a lot of these other counties just kept on doing it, and we stopped.
You know, I was reading because Luke Bergman told me that we had 1,285 conservatorships before the pandemic. Now we have 380 in the county of San Diego. And I was trying to understand how that had come to be. And I was doing a little reading, and I just wonder if you have any awareness of this. The city county of San Francisco has 7 times by population the number of conservators.
That's interesting, yeah.
Conservatorship that we do. So we've made a decision in San Diego County that we don't like conservatorship and we don't want to do it.
Well, part of it is it's an infringement on civil rights, but part of it is you got to have a funding source and you got to have a place for somebody to go.
I don't agree that it's an infringement on civil liberties. Okay, you have the right to a unanimous jury verdict. You have the right to a jury and a unanimous 12-person jury verdict. You have the right to a lawyer to defend you. You have the right to a patient's right advocate. You have the right to a psychiatrist's diagnosis. So we're not infringing, but I think it's important the way we talk about it because a lot of the community thinks that it's taking people's civil liberties away from them. You know, it's not, if you rob a bank, we haven't taken your civil liberties away from you, that we've incarcerated you. Your civil liberty is to have a fair trial, right? Your civil liberty is to have due process. Your civil liberty is to have the protections of the Constitution and of law upheld. So it is vital, you and I are both civil libertarians and would both, fight for any person's right to have their constitutional and legal rights upheld. But once those constitutional and legal rights are upheld, then I think it's very important because it's somehow become political in this county. And I'm looking at the things that Gavin Newsom says. He is stridently in favor of expanding the use of conservatorship. I'm looking at what they're doing in San Francisco, and then I'm looking at what we're doing here. And I'm like, what's different about our politics in San Diego County than San Francisco County? I mean, clearly there's a significant difference of approach. And when I talk to, what's the doctor's name is the chief medical officer at Rosecrans?
Krelstein, Dr. Michael Krelstein.
Yeah. I sat with him and Luke Bergman and the lady who's the chief administrator there at Rosecrans.
Angela Warnicki.
Yeah. The three of us were in that conference room there. And, he basically told me, as much as I could get, and I think I'm one of the few electeds who's gone down there and visited with them personally, basically, they're not keeping anybody that doesn't want to stay voluntarily. Almost doesn't happen. So pretty much all the 5150s get delivered there. They're gone in an hour, 2 or 3. They're trying to get them out as soon as possible. And they told me they're focused on the people that voluntarily want to stay and want the help. It's a problem because, I talk about a woman that I met in front of Vista Paint, and she was hit by a car and wasn't well enough. I call anosognosia. I break that down as too sick to know you're sick, right? And she got hit by a car, and her leg is bent this way for the rest of her life because she was too sick to realize that she should seek medical treatment. And she was insistent that she owned the building that she was camping in front of, and that she lived on the second floor of that building. It was only a 1-story building. So clearly she didn't own the building or live on the non-existent second floor. And you could see with this woman's leg in a permanent state of damage that she was harmed by her substance abuse and her narcotic-induced psychosis. And, we got Walter Vedovic has lived as an alcoholic for 30 years in our community. I've been begging the system to work for this one man, and he's, we haven't seen him for a few months, but he pops up again, and he's been homeless we've arrested him 350 times, Walter Vedovic, 350 times, more than any other person in Vista. We failed him. We don't want to help him get off the street. We had, was it Thomas Smith? Was that the gentleman's name who was homeless for nearly 40 years? That we got, finally, we got him into permanent supportive housing, but only after he was laying in a pile of his own feces in a terrible situation. And finally we were able to help him after, was it 40 years? Yeah, 40 years of homelessness. And then we've got this guy, Mark, who I've gone to visit with personally, who we think he's sober, but he's too mentally ill to say yes. We had a VASH housing voucher for him, and for 30 days it was open and available to him, and we either couldn't find him or he wouldn't go. When he had 10 chihuahuas in a shopping basket, the whole neighborhood, the whole city went crazy on Nextdoor, and everybody demanded, and the Humane Society, of course, intervened because we care about dogs. My point is we don't care about human beings the same as we care about dogs, apparently. It's sick. We are really depraved in our society, all of us, that we have not solved this problem yet. I am so frustrated to see people who are in a state of crisis, who are abandoned. We had 400 people died unsheltered of overdose last year, according to the county coroner report. Did you see that?
No.
Yeah, there were 400 people that were unsheltered who died of overdose. There are only 6,600 people. That's a 6% rate of death. Do the multiplication of that over about 5 years. What's your odds of dying on the street? It's a death sentence to live in an encampment addicted to substance. These people are sentenced to death as soon as they begin to reside there. Statistically, they're very likely to die. And they're living in these horrible circumstances. For those of us who've been in the encampments, I've seen a 4-foot-tall stack of bottles filled with excrement and urine. Stench is terrible. People are covered with festering sores. They're starting fires. So You didn't come here to take sides on this, but it's very important that we speak with heart about the people who are not getting care that they need and not continue to leave them on the street, because to me, that is the symptom of a very sick society, one that is immoral, that has not stood up for those who are the least among us and for their families. Father that I flagged down when I was talking to somebody else who was homeless, and he was driving around looking for a place to let his son out, and his son was getting out of the car. His son was about my age. Father was in his 70s, and the son was trying to get through a chain link fence. Obviously, he was looking for somewhere to camp, but the father had a serviceable automobile, and I said, if you guys need shelter, we can help you get in the shelter. And he said, I'm not homeless. I live here in the neighborhood. He said, this is my youngest son. His older brother died a year ago, fentanyl, the day he got out of jail. And now his younger brother is addicted to fentanyl, and he's dangerous, so we can't have him at the house. But I said, I go out and I find him every week or so. We bring him home, we get him a shower, we clean his clothes, feed him. He said, but then I have to bring him back out here because he can't stay with us. And I mean, the tears and the pain in that man's eyes, because he knew that son was going to die too, if not from overdose. So these are people that live right here in our community. I met Kristen, as a young woman who's being pimped and sold into, sexual servitude by her boyfriend, Steven, right in front of the Burlington Coat Factory. Her mother lives here in Vista. She became homeless in Vista. These are our kids. These are our neighbors. And, she was passed out in a drug stupor. And I called 5 different service organizations. I had some ladies who were recovered from homelessness reach out and try and, connect with her. And she was too much under the grip of the drugs and the control of this person that she was with. So I just see a lot of people in true crisis that are really suffering physically. They're suffering emotionally, mentally, and I see their families are suffering because government has not done its job. Society has not done its job, really, to step in to help these folks. So, yeah, I think the pendulum does need to swing back a little bit. Obviously, we need to do everything we can to protect people's civil liberties. But also, we talk about money. We've spent $16 million as a city over the last 4 years. We have 170 homeless people. We had fewer last year. If we said there were 170 over 4 years, that's $25,000 per person per year. So clearly, the approach that we're taking, based on the numbers, is actually, if we believe they're correlated, and I think they are, it's actually making the problem worse. So I think we do need to invest. I was the only elected leader at the grand opening of the Lakeside Special Treatment Center. Mm-hmm. Have you been there?
I have many times.
Beautiful facility, the new facility for conservatorship. I think we need to build more of those. I think with the 6,600 people we have on the streets of San Diego County, I think if we could get a few hundred more into conservatorship through that due process, off the streets, clean, safe place to live, very humane and hospitable and warm and residential, I think we could help a lot of people. But we've statistically approached the people in our community and asked them to take shelter 20 times a piece. And those are old numbers. We're probably closer to 25 or 30 now times that we've asked, and we have a 94% decline rate. They say no, they don't want the help. And I go with the deputies into the encampments, and I hear a lot of non-reasons why they don't want to go. And I beg people, I'm like, just come eat a sandwich at the shelter. Just come meet the people there, And I'm very proud of our shelter. We have a 57% successful exit rate, which is unheard of. But we're doing some cool stuff. But we got to get people to go to the shelter. And if they won't go, if they won't accept that treatment, then, we can't begin to solve the problem for them. Right. So this is a super important discussion. I'm willing to look at Vista being a site for a special treatment facility. Special treatment facility really helps these people get off the streets. It's egress controlled, so there's not a spillover or spill out into the community like a lot of other services have, people that may, have issues and they wind up on the street in front of the facility. That doesn't happen with special treatment because it's a controlled, they call it egress controlled, which is a nice way to say you cannot leave.
Delayed egress sometimes.
Yeah. So, but also it's a lot of good jobs in a facility like that. But I think we need to move the dollars from outreach. Instead of asking somebody 20 times, I think we should ask them a few times. And then if they're saying, no, I'd prefer to stay on heroin in the encampment, then I think we should say, well, I'm sorry, but that's not good for you. And it's not the loving and caring thing. So we're not going to let you do that. We're going to take you and get you into 5150 and go through the process, honor your constitutional liberties and your legal rights, and then help people get off the streets. And we talk a lot about involuntary versus voluntary and where people are at a place, and we all agree that it's more effective to help people when they're at a place where they want it, right? You said that, and I agree with that. However, there are many people in New York State, Rhode Island State, Connecticut, on the East Coast. Again, it's so interesting because this is not a left or right thing. But it is regional. There's really different approaches in different regions of the country. And in those areas, which again they're not necessarily more conservative than we are here at all, but they are strong believers and implementers of involuntary treatment. They're strong implementers of court-mandated medication-assisted treatment, those kind of things. And there are plenty of people that you can find that say, that intervention saved my life. And, so I'm looking at those 400 people a year that die who are unsheltered of overdose on the streets of our county and saying, how many of those children could we save if we were to step up and intervene in what is effectively, and this is where I get frustrated with the definition of danger to yourself, because danger to yourself is, as defined currently, and as you said, there's not a lot of specific definition to it, but the way it's defined is I am actively pushing the knife into my chest or like holding a gun to my head. That is the only level of you're actually, because if I'm simply laying in a pile of my own excrement and have a needle hanging out of my arm, nope, no danger to yourself there, you're good. And how is that not a danger to yourself? I mean, clearly you're in a situation which a reasonable person, which would be anybody that doesn't work in any of these industries, if I get 12 people off the street at random and said, do you think what this person's doing is dangerous for their health? They'd all go, well, yeah. But we've lost all reasonable, rational perspective on this. So sorry for the diatribe, but it's very frustrating because we are leaving people to suffer that everybody can see as they drive on their way to work, are screaming at lampposts at the top of their lungs. There was a guy took a picture because he was laying with his legs in the lane of travel, just waiting. I mean, he's passed out and his legs are just laying there in the middle of the road. Everybody's driving around him. The guy's just tempting fate for somebody to cut his legs off with their car. And so I called the deputies and said, you got to get this guy out of the road, and it's every day here. Starbucks the other morning, and this happened at the motel on Santa Fe. There's somebody living in my trash enclosure. Edco shows up. Edco says, nope, not going to empty your trash because I can't lift up the container or put it back down with a person underneath it. So you have to solve that problem. We came across Justin there. Justin told me that he was a famous rapper and he owned 3 homes. He also said he was Jesus Christ and had a number of other delusions, and clearly was not somebody who was taking care of himself, and had absolutely no desire for help. So I just think this is extremely important. I would love to spend more time on this, and I think very, very few policymakers understand the continuum of okay, from the observation of a deputy or another clinical professional to the emergency department to, you know, a psychiatric or a PUF or a CSU. Like, what's the org chart or the track, if you will, you know, do you guys have a diagram for that? I think a lot of people need to understand like what the pathway is. And then the thing I wanted to do most is I wanted to just vocalize that protecting people's civil liberties is part of this process. It's the core of it. It's the reason that we have all these LPS and 22. So 2275 sounds like the legal construct to protect people's rights at a non-LPS facility, right?
That's correct.
So we have all these constructs to protect people's civil liberties, and I think it's important. I don't see a bias in the system right now at all to take people's liberties away from them. I see a strong bias to protect people's liberties at all costs, even at a cost of negligence to our human duty to these individuals. And so I think it's important that we describe it in terms of, you know, all the things that we're doing. All of this bureaucracy is all about protecting somebody's civil liberties, because go back before 67 and they just threw them in there and a doctor said, we're keeping them, right? So I think it's important that we do educate people that we very much care about people's civil liberties and they are very much protected in this model. And so you're actually a patient's right advocate, and that's what you do, is help people understand their rights and help them fully exercise their rights, right? And if you see somebody who's being maligned by the system or not fully informed or not able to utilize their privilege and right, not privilege, their rights under the law, then your job is to step in and call that out and make sure that their rights are upheld, right?
Yes.
That's good. So very important for people to realize that somebody like you, a patient's right advocate, is available to every single person in the state of California who is at threat of having their liberty abridged. Because most people don't realize that. And I think that's really, really a huge point of education for the community. Okay, I'm done. Thank
Well, I
you.
appreciate that, Mayor. It's clear that this new law, and as we're implementing it, is attempting its very best to preserve civil liberties. And while people who are under this new definition of grave disability aren't necessarily committing a crime such as robbing a bank, they do clearly need help and intervention. And we will see if it is effective in resolving their mental crises and assisting them in recovery for their substance use disorder. So I join you and support your comments in providing the material resources for this law as it's going into effect to have the desired outcome that we're looking for. We clearly need more facilities. That's my biggest takeaway from this conversation, is that it is not enough to identify someone as being gravely disabled and then not provide them with their material needs. That is a true sin, to know that someone cannot take care of themselves and then to continue and persist in putting them in a position to be self-reliant on a system that does not have enough resources for all people, especially those who can't access those resources by themselves. I wanted to make a quick comment on some of these other changes mentioned here, that an assisted outpatient treatment and the CARE Act must be considered before placing an individual on LPS conservatorship. And we mentioned before that, as much as we know that people need an intervention when they're at that crisis moment, we do need to, or would benefit from, a system improvement where we are intervening sooner. And I've talked to Dr. Bergman, the county, about this too, where it's not enough for us to intervene in a crisis. We have to build mental and behavioral health into our day-to-day public welfare and into all of our services that we're offering. what is the incentive for us to expand and ensure the advancement of outpatient and voluntary programs when SB 43 is in effect?
Yeah, I think, again, as I mentioned earlier, this idea that we continue to add inpatient beds in the highest level of care, we're undercutting the ability to take the pressure off of those systems. I would argue that even back in the 60s and 70s when we implemented this, we let everybody go, but we didn't provide the services in the community. We've never fulfilled that promise to our communities. So they either failed that system because they chose to, or we never built the system that they could have availed themselves in the first place. So part of the reason that the pendulum is swinging now is we never really built a system that might have taken that pressure off, and now we're deciding, okay, we've got to, be more serious about this. Totally fair, but we never built those services.
So I would, call upon all of our leadership, Mayor, that as we're looking at long-term planning, first we need to respond to the patients that are going to be arriving via SB 43. And I'm ready to do that in Vista. I think we have some avenues and ways for us to accomplish that. But in the long term, let's work together on mental and behavioral health in our day-to-day in our community, because just as I saw with my neighbor, where he seemingly very rapidly descended into chaos and ended up being a danger to himself, he I know, needed support for much longer. And it's the stigma, right? Which I think in the past decade, we've seen a cultural shift when it comes to mental health. I think that's a very good thing. We should lean into that. And I do believe that it would be cost savings and life saving to invest more in that day-to-day mental health, whether it's advocacy to the county for us to be able to provide more of those services to our community. But we need a more robust ecosystem. And clearly what's missing here is facilities for people who are going to be joining us from SB 43. But I am concerned that with the utilization of SB 43, that it will reduce the incentives for decision makers to actually build those robust community mental health services that we need. Because as much as we're saying they have to find an alternative first, if we reduce those alternatives more and more, then LPS conservatorship will be the only way.
And
I don't want that path.
And I can speak to that if I could. So this particular change is really a semantics change. Prior to this code section existed and it just said all lesser restrictive methods must be considered first. This was adding in some of the new innovations, care court and assisted outpatient treatment, essentially just calling them out by name. Those are considered, whether they should be or not, lesser interventions. The idea being that we should try those interventions before we try conservatorship. This plays out in a technical way in the hospitals, where hospital might be petitioning for conservatorship, and then they reach out to the conservator's office and says, wait a second, we've got to consider care court. That's on a different timeline, a different track, and so all of a sudden the bureaucratic processes can sort of get tangled up, and then the hospital says, how long am I supposed to keep this person here and under what authority? So this is really just calling out by name some of the new processes. Otherwise, this particular code section is essentially as it was written before.
Okay. And I would support what the mayor is asking for if we could have more information provided to our council and staff on what is the flow chart, right? That we're
I would say
working with now.
Dr. Bergman is very much proud of, and he's been working on it for several years now, what he calls the optimal care pathway. And it's all about all of these different things and how they can fit together and how they can take pressure off the highest level, most expensive level of care and waiting till people get totally acute and all the missed opportunities to engage. So he could go on and on about that. And so I can reach out, but you all have access to Dr. Bergman as well. He can speak to all those things.
Well, oh, go ahead.
Please.
I was going to say it'd be great if we had more opportunities to have dialogue with Dr. Bergman in a room full of our colleagues regionally, because we're very much, the county is making these decisions in a vacuum and really doesn't proactively a lot of times consult the cities, but we are we're the boots on the ground.
That's right.
One of the things we at our shelter, we know, I have these numbers from the net who's sitting behind you because she's our data scientist there. The first 163 days of operation, we were at capacity 5 days. So we know that, but all but 5 days, we had capacity. And so my question is, you said there were 790 beds?
A few years ago, there were. That was the total a few years ago. I can get the current total.
So one of the things that I
Those are
ask...
inpatient beds, inpatient behavioral health beds.
Yes. One of the things I like to ask is, what's the average duration to stay? And, how many days do we have vacancy? What's the total number of bed nights
I
available?
can tell you, in the inpatient hospitalization beds you're talking about, so in those beds, typically you're looking at a 5 to 7 day stay, and reimbursement for those facilities is like 3 to 5 days. So these hospitals, this is a money-losing business. There people get injured in these settings. It's difficult to staff. And to your comment earlier about the other states having good outcomes, it's been my experience that depending on the amount of money and resources that are contributed to that problem, that results in better outcomes. So I think more resources, more funding lead to those better outcomes.
I think it's funding the right effort, right? Because I doubt there's any state that's put more dollars into these problems than the state of California has. When we divide out the number of dollars that we're spending over the 180,000 chronically homeless people that we report to the federal government as a state, the state's spending about $25,000 per person per year. At one point during the pandemic with ARPA and other pandemic monies, the number was closer to $80,000 per person. So it's not, we've reached a point where I can confidently look you in the eye and say, it's not a money problem anymore. It's not a money problem. It's a resource allocation problem. It's just like, we don't have a food shortage in our country. If there are people who are starving, it's because we have a distribution problem. We're not getting the food to those people, but we know we're throwing away a lot more food in this country than would be required to feed those people who aren't getting it, right? We need to speak honestly about where we're spending money and it's not working, because money does not grow on trees, and we have to, we can't just always go back and go, well, if we just had more money. We've got the money. We are spending the money. We are dedicated to spending money. But if I have to pursue somebody for 20 or 40 years, and I have to absorb all the costly impacts of paramedic visits and the cops team, it costs now $350,000 a year for a single deputy. And I'm sure the PERT team, fully loaded, is probably at least double that, right? So we have to, and this is something we don't do. We don't want to know what we spend money on that doesn't work. Don't want to know. Absolutely don't want to know. Refuse to want to know, because there's a constituency that would lose that funding, that would complain that they have at least 3 cases where they've done some very excellent things, right? And they would come forward and they would bring those people and they would say, but what about this one person we helped? Well, the reality is we're clearly spending money on things that are either not working or they're actually making the problem worse. This is what a world I'd like to imagine. What if we never tolerated somebody living outside? How much trauma could we prevent if we said, you're not allowed to live outside? Just not. I'm sorry that you want to, but it's not lawful and we're not going to tolerate it. If we were to get that person off the streets, literally in the first 24 to 48 hours, because we were just so intolerant of anybody living outside, how much cheaper and more effective would it be to intervene to their benefit if we were to do that up front rather than allowing them to be there for 4 to 40 years to develop an, what do they call it? Service resistancy, right? Our approach is really super not working. And it's led to massive increases in the numbers of unsheltered people. I think if we got out there and said, we're just, we apologize because we are so broken and so wrong that we've left you here for so many years. Clearly it was inhuman what we did to you, and we're here to apologize by bringing you to the help that you need and getting you some compassionate assistance. Even if you're anosognosia, and I appreciate you bringing that concept up, because 5 years ago you didn't hear anybody talk about that or even know what it was. But that is a super important concept. Again, I don't think most people understand. Too sick to know they're sick. That's how I say it, because a lot of the people out there are too sick to know that they're sick and would benefit from treatment. I would love it if the county would publish, because how do we encourage our local hospitals? When I saw Palomar open 100 or break ground on 120 beds, I kind of publicly said, and this is exactly what I use the words weak sauce when I describe what Tri-City's doing with 16 beds. Why couldn't they figure out how to build 120, right? We don't need 16 beds, we need 120.
Some of that's going to depend on how those beds end up getting funded. If they're funded through private insurance, then there's a lot more motivation to build those types of larger facilities.
I agree, and that's why when Congressman Mike Levin was here, I talked to him about the Institutes for Mental Disease Exclusion. Everybody wants to blame Ronald Reagan, and fine, blame Ronald Reagan, but that was 50 years ago that we largely defunded the federal dollars for state mental institutions. But that was part of the Medicare, conversation. They were excluded from Medicare because Congress was funding them. And so we created this, what's called IMD, or Institutes for Mental Disease Exclusion, that says if you have 17 or more beds, you cannot receive Medicaid reimbursement.
That's right.
But if you have 16 or fewer, then you can. So when they said they're building 16 beds, it didn't take me long to figure out where they came up with that number.
Sure.
Pretty obvious. But we need our public health institutions that are owned by the people and operated for the benefit of the people. And I understand they have to pay for what they're doing over there. But speak up and ask the cities, ask the county for the money, and just say, we would like to build 120 beds, but we don't have a model to pay for it. Who will help us? We're ready. We have the land. We have the desire to do it. We have the desire to operate it. But if you don't use this thing and tell people that we can't pay for it, we're willing, but we need the money, and get out there every day, and then come here to this chamber and ask us, and go to Carlsbad and go to Oceanside and say, we need you to advocate with your state legislators. We need this to solve the problem. That conversation is not happening. And so one of the things I've been talking about for a number of years is this inventory of shelter beds, inventory of psychiatric beds. It's not really widely publicized. And then the utilization, how many days were vacant, how many bed nights were utilized. If you have 100 bed nights over 365 days, you get X number of bed nights. How many of them did you use? How many of them were vacant? And then you can start to think about, do we really need more resources, more beds, or do we just need to better manage the beds we have?
The impact on the beds right now, so the inpatient hospital beds are all full and are always full. And I heard what you said before about danger to self. We see, it's like the parable of all the blind individuals describing the elephant. Everybody's right about whatever part that they know. We see most of the 5150s that come in through our work and going into the hospitals. There's a lot of people who are detained because they're wandering in traffic, because they aren't taking care of medical conditions. So all of your stories are true, but there are a lot of people that are brought in for those reasons. And what's really happening is because of the impact and the turnover rate and the need to turn over those beds because there's just no room and the emergency rooms are full, off record, administrators of these facilities will say to me, Mike, the definition has become, danger to self has become that I didn't try to kill myself today.
Right.
And I didn't try to kill someone else today. Not because that's what anybody wants to interpret it as, but because of the impact of the system and the need to free those beds up and unclog the jam. And I see, you know, when you mentioned before, I'm leading today with my civil rights hat on. I oversee multiple programs, and I see all of this. I oversee the safe parking program. You're going to hear from Director Nicole McCune in a moment. I oversee the patient advocacy program. Also through Jewish Family Service, we run a very large permanent supportive housing program and case management throughout Riverside and San Bernardino counties. So I see all of it. I don't speak for the conservator's office, and I don't speak for behavioral health services. They may lead with civil rights as a reason why they're doing this or that, but, and it's maybe about the allocation as you described, there are no places to put people on conservatorship. All those beds are full. They don't have the placements, and they're trying to get every psychiatric hospital in San Diego County has one or more patients that have been there for a year or 2 years waiting for one of those beds to open up.
Well, we've
Waiting for the state hospital to
We've
open.
got 6,600 unsheltered people in San Diego County, according to the point-in-time count. We just opened 120 new beds in Lakeside. Where are we going to build the next ones? Do you know? Does anybody know? You know, why are we not having that conversation? And that's why I've said I think maybe we should look for a place, because we have 170 unsheltered people in Vista. Maybe we should be building 120 special treatment beds in a facility that, you know, from the outside of it, nobody even really knows what's there. You know, it's a problem-solving facility. You know, it's not a problem-creating facility. It's you know, I carry pictures on my phone, and I show people what a nice facility it is, because it's gorgeous inside, and you know, they teach people how to do their laundry, comb their hair, make their bed, and I think they said they had 27 activities of daily life was a term I learned there,
Right.
that they help people recover the ability to live independently, hopefully. But we have to, and you know, we're in Vista, you know, you know, I was one of the people who said we need permanent supportive housing. And we've been probably the only cities that has said we will do that here. You know, we want to make sure it doesn't have some of the problems that, say, a Windsor Point has. And we also think that we can manage it better if we build it and we operate it. You know, our shelter operates next to a county-funded, contract-operated facility that I'm not so impressed with, because nobody from the county is stopping by 3 times a month to check on it. But I know all of us do. I stop by the shelter more often than the shelter staff would like. And it just figure out what's going on there, meet the people. I think it's better when we have facilities run by the cities, because if the council people who are closest to the people in that city, if they stop in and they ask questions and they see what's going on there, then we have better opportunities. So I appreciate the information very much. I'd like to get your business cards.
Sure, of course.
And I'd like to follow up and continue the conversation on this, because this is going to become much more important in the next couple of months and years.
And I'll say that Proposition 1 is designed to build and create new facilities, but you're exactly right about the IMD exclusion. That was based on research at the time, and I believe it's supposedly still valid, that anything larger than a 16-bed facility was less conducive to recovery. So based on that, the feds and the state said, okay, if you want to build anything more than 16 beds, you're on your own. So when you look at Alpine Special Treatment Center, when you look, and Lakeside, even though it's a skilled nursing facility, it really operates as a mental health rehabilitation center, which is the licensing category under IMDs. When you look at Crestwood Fallbrook, Crestwood San Diego, Crestwood Chula Vista, those are fully funded by county dollars. So we're not able to leverage, other than certain medications, any kind of reimbursement in those facilities. So to have to commit that much money at a local level to have those kinds of facilities, that's a huge ask. And the data supposedly is still true that anything larger than a 16-bed facility is less conducive, but you can't, that's not going to solve the problem, and it's not going to work with economies of scale and the sizes that we need. So the commitment of communities to build these facilities, my only ask is that as we do these things, let's not let them end up looking like the facilities of old. Let's not let them look like the One Flew Over the Cuckoo's Nest facilities that were horrible places where you just disappeared people. We can build those.
Absolutely agree with you. And I think we have a record here in Vista of providing the most dignified services. And so I would join you, Mayor, in making that recommendation to the whole of the council that we do pursue with the consultation of all of our partners to find funding and resources to be able to provide those material, beds, housing, shelter, specialty shelter services, and housing services for people who are impacted by this new law. As you may have mentioned, you will be speaking on the safe parking program. Is that expected to be on our item 3? Okay, I would want to move that item up so that we can have you
Actually,
participate.
Director McCune is actually going to speak to that.
Okay,
if
well,
possible.
we did have another item before them, but since you're here, I'd like to move that item up. So if we're concluded with this portion of the presentation, I think we had a really great discussion. Let's continue the dialogue and see what potential partnerships there are there for our city. And Mayor, if you didn't have any other questions, and if you're amenable to moving the general homelessness discussion up so that our partners here can participate sooner rather than later.
Of course, my last thought on what your closing thought was, you know, when Geraldo went into Willowbrook and showed America what some of the worst of these institutions looks like, I think that was the denouement, the untying factor of the federally funded mental institutions, and for good cause, because it was, you know, shocked the conscience what was happening there. But I think, you know, that was more a symptom of a different time. And, you know, the asylums of the 1800s evolved over 100 years into something that, you know, were poorly funded. But we have so much better understanding now. We have so much better compassion. We understand that most of us are struggling with some kind of mental health. So I don't think our society would ever repeat those errors. And I think, you know, we're just in a better place as a species to not repeat those errors. But I think we're all committed to that. And certainly, we'd love everybody to be in a residential environment that's loving and small, you know, with lots of one-on-one care. We wish we could afford to do that, but obviously, you know, when we're talking about doctors and medical staff, we have to spread those people over a larger patient population. So, yeah, we do have to change things. And that's why I asked Congressman Levin to take that up and lead on that issue. And I've asked other members of Congress to look at that. And, you know, they don't, Congress as a whole doesn't want to do more. They like the idea, or that the fact that the public thinks that this is exclusively a local issue. And clearly, this is one that's going to require all 4 levels of government to be fully engaged on as funding partners and policymakers in order to solve. Thank you for being here.
Thank you.
Thank
and
you.
as we transition, I'd love to say a public thank you in front of all of you to Jonathan, Daniel, and Imelda, who have been absolutely fantastic to work with in the context of our safe parking. So just want to say that. And also, I'll give these business cards.
Thank you very much. Yes, please.
Yeah, if you want to share them with Imelda here.
Yes, please.
Just want to say thank you for your time and your compassion. I was specifically brought onto this team to spread education about SB 43. So rest assured, we're here to support. Last month, we reached hundreds of individuals, over 30 community providers in San Diego County, and we're just going to keep on trucking. So anything you need, we're here for it.
Thank you for your work. This has been wonderful, and it's a complicated, challenging issue, but we're working together on it. So we will go ahead. Thank you.
Thank you very much. Appreciate you.
We will go ahead and move to item 3 and receive our general homelessness update. Again, if any members of the public would wish to speak on this item, press 9 or raise your hand, submitting a speaker card. Do we have any members who wish to speak?
No speakers.
Alrighty. Our Homeless Services Program Manager, Jonathan Lung, will provide the staff report. And thank you for being here. Thank you.
Thank you, Deputy Mayor. Good morning, and good morning, Mayor. This item will provide updates for each of the contracted programs in support of the strategic plan. We also have some of our plan partners here that will present the data for their programs. Start with outreach. During the month of August, there were 124 clients engaged by Exodus Recovery during outreach, 27 of which were engaged for the first time in August. There were a total of 124 of those clients, those 124 clients were referred by various sources, the most common being from Housing and Homeless Services staff, self-referral, and of course, during street outreach with Exodus staff. There you can see two charts there of the distribution of the ages and genders of the clients served this month, as well as the racial demographics to the right.
I'm going to make a request going forward. I want you to break this dashboard into two pieces because I just can't read it.
Sure.
It's just too small, and I didn't bring my glasses this morning.
It's not a problem. Okay, moving forward with the location of the most recent referral, meaning the location that these individuals are engaged. 81 of them on private property, 22 from the City of Vista property or right-of-way, not including the Hacienda BPO, 14 on county, NCTD, or other public property not owned by the City of Vista, and 7 within the Hacienda BPO. Various referrals for services were provided for a total of 59 instances of referrals, the most common being for housing navigation services and shelter referrals. On the bottom left, you'll see there the last known housing status of 114 clients included 49 in some form of permanent housing, 36 in place not meant for human habitation, and 29 in various temporary accommodations. And on the bottom right, you'll see a total of 20 shelter referrals were provided during the month of August, 13 to the BCNC, 3 to La Posada, 2 to Haven House, 1 to a DV shelter, and 1 to Operation Hope. Next up is VHAP, which staff would like to remind the Committee of Program Eligibility as approved by the City Council in August of 2023. This includes that the applicants must be a resident of Incorporated Vista. They qualified for unemployment benefits or experienced a reduction in household income, incurred significant costs, or experienced other financial hardship during or due, directly or indirectly, to the coronavirus pandemic. One or more household members can demonstrate a risk of experiencing homelessness or housing instability, and household income may not exceed 65% AMI.
We talked about this at our last meeting, but I want to move forward with a full council level discussion. So I'm going to ask the city manager to put on the agenda. I want to open these funds to the individuals who are in our shelters, who are recovering from chronic homelessness. They have no pool of money. We've done this homelessness prevention, but we have not done any rehousing dollars. So, I mean, there are people in the shelter right now who we're giving out an average of $10,000 here. There are people that, $3,000 would get them into an apartment, right? And they have no pool of money. And so I understand, keeping people from becoming homeless. And when we approved these dollars, I believed that these were people who were going to be evicted. I believed through our discussion that they had a pending eviction. And I come now to understand that is not the case. So there are many people, I am not in economic hardship at this time of my life, but I have lived through economic hardship. I have had not enough money to fill my gas tank or to buy the things I needed as necessities. So I've been there, and I understand that need. But when we're dealing with people who are not imminently going to lose their housing, that was what I understood. They were going to imminently lose their housing. That was what this was sold to me as. And I won't vote for it again because it is not for people who are imminently going to lose their housing. And that is very problematic and troubling to me because it's not available to individuals who our shelter staff believe that $3,000 would get them back into a housing situation and potentially open those beds back up at our shelter and help us help the next person. If we're going to give money to individuals in need, as I weigh the need of somebody who has a financial downturn but is not going to be imminently homeless versus somebody who is now homeless in an emergency shelter and could benefit from a few $1,000s, I would just like to open this pool of money to a rehousing fund. If we can devise one as a council that would help our shelter and case managers get people who are chronically homeless. Okay, I want to open it to I want to solve the problem for the people in the greatest need first. I want to triage. I want to help the people with the compound fracture before I help the people with the flu. All right, I will get to the people with the flu because it's the right thing to do, but we need to help the people with the compound fracture first. So I'd like to propose that. Sorry to be long-winded about it, but I'd like to see that change.
I support funds being utilized for rapid rehousing as well.
Staff, of course, are always looking for opportunities to fund rapid rehousing funds. Unfortunately, this program is funded by ARPA, and rehousing is not an eligible expense. It is designed from the funding source to provide rental assistance for housing retention and homelessness prevention. But we will find additional funding sources to fund rapid rehousing.
And this was a grant totaling how much?
This is ARPA funds. The total allocation, I don't know off the top of my head, but for VHAB, 1.4 was allocated.
Okay.
Bring me a list of things that are lawfully allowed, and I'll figure out how to word it.
Sure. Okay, moving forward, documenting need for VHAP eligibility. Applicants must provide a termination notice, or any combination of these documents are appropriate. Termination notice, payroll check or pay stubs, bank statements, medical bill or provider notice, letter from employer, unemployment award letter, or self-certification. During the month of August, 20 applications were approved for a total paid assistance of $192,000. The majority of the approved applications were for the limit of $10,000. Other public assistance received by the approved applicants include Medi-Cal, CalFresh, CalWorks, and WIC. Other MAC programs referred to included 11 referrals for the financial education coaching. A total of 27 applicants were denied in the month of August, with the majority of those applications denied for non-VISTA residents, and a couple for incomplete applications. Since the inception of the program, 81 applications have been approved for a total award of over $732,000.
And remind me, they had to have an income of less than how much?
65% AMI for the household. And so it's adjusted for the size of the household. You'll see the chart there at the bottom.
Okay.
Yep.
So an individual earning $60,000 would qualify for a $10,000 payment.
If they could also demonstrate a need, which could be a reduction in income or an increase in unexpected expenses.
Yeah.
Yeah.
Do we have any data on what the actual average income of the participants that we've brought in
Yes.
is? Could we have that? Do you have that available now?
Not at the moment, but we can get that.
It'd be nice to see. I wonder if it is 65 or if it's significantly less than that.
I'd also like to see that number changed to, I don't know, 35% instead of 65%. I just think we ought to be helping people who are really struggling, and there are plenty of people in our city, because remember, you're using a countywide AMI, and our city AMI is 25% less than the county average, so, or the county median. So our number should be lower. If nothing else, make it 25% lower than what it is, but you know, we're significant. The AMI for a single person now is 119,500, right?
Sounds correct, yeah.
That's what it is.
For San Diego County.
So, I mean, that is not the AMI for a single person in Vista. So I would like to see this money going to people who are truly low income working families before it goes to people making 60,000. And I see the only people we're declining here are people who don't live in Vista or couldn't fill out the application correctly. How unfortunate that they couldn't get their application filled out correctly because they could have gotten $10,000. I just think, you know, and I think $10,000 is an awful lot of money to be handing out. I would think $5,000 would be a more appropriate maximum, so we could help a greater number of people. We could help twice as many people. And, you know, if $5,000 isn't enough to cure your imminent homelessness, the other thing I'd like to bring this whole thing back, because I think this should be for imminent homelessness. I did not know that this, I mean, homelessness prevention is what we were talking about. I did not know that this thing has morphed into you're down on your luck and we're going to hand out $10,000 to every single person who has some kind of an economic downturn. I thought it was going to be for imminent homelessness. Literally, I thought the people were going to have a notice of eviction, and we were going to be stepping in to help people who had not been able to pay their rent, and they were going to be imminently, as in the next 3 business days, were going to be evicted by the sheriff's department. And that is not what we're doing here. So I think we need to really reapproach with the remaining 462,000 or whatever. There's probably only $250,000 left. But with the rest of it, I think we ought to be a little bit more judicious about how we pay this money out.
I'm not opposed to additional criteria at all. I do know that when an individual reaches that 3-day threshold, I've brought many incidents to our staff where someone is experiencing that, and the administration of those funds within that 3-day window is very challenging. So I would like to see what would be the staff impact. How can we make sure that these funds are, if we do provide these funds for people who are in a more urgent situation, then we will need to have a faster response. I think Conley had a update.
I was just going to say, Mayor, as far as changes to the program, we can certainly agendize it for the rest of the council, but it would obviously be the majority of the council to make those decisions.
Yeah,
Sure.
we'd add it to an upcoming discussion.
Because when this money is gone, we don't have a funding source identified for any more of it.
That's correct.
Yeah, I think we could help more people and people who are maybe in a greater level of need. But maybe you'll bring the numbers back. But here's the thing: if somebody qualified at 60,000, they're not making a qualitative decision, are they? And MAC hasn't come back to tell us what they're doing, but they're not going, you make 60,000. I have somebody over here who's making 17,000, and I think they need it worse, so I'm going to give it to them. They're not doing that. They're just saying, your application is completed correctly, and you've checked all the boxes. Here's your $10,000. Because that's what we've asked them to do. And if that's not true, what I've just said, then somebody tell me that that's not true. It sounds like that's exactly what's going on. So we need to, if they're not going to make a qualitative decision about who has a higher need priority, then I think we need to create criteria that would tend to filter people who would have a lesser need and prioritize people with a greater need.
I understand. I want to make a comment on the existing funding. I think the ARPA money has to be spent, if I'm not mistaken, by the
So
end
it
of
has
the
to be
year.
fully allocated by the end of the year, fully spent by the end of 2026.
Okay, so we have till the
That's
end of
not a problem. We
26.
can still
Look, well, we're spending
enhance
200 a month.
criteria.
We only have 2 months of funding left.
So we'll bring it back for discussion. and
This
we
is August. September is nearly gone. Probably we only have 300,000 at best left in this account. By the time we get it back to us, it'll probably be almost completely
That's
gone.
probably close to correct.
Yeah, well,
But we'll bring it back, and we can also look at additional funding options.
let's have a conversation before we utilize the council's time on this. Let's look at how much money's left and how much would be left by the time we get to a council discussion.
Will do.
It might be a moot point, but if we're going to reauthorize this with any new source of funding, then I think we'll want to look
And
much
with
more.
what you're
closely.
describing, Mayor, a new source of funding might be available for that rapid rehousing, which I would say is a higher priority.
I want to help people get out of our shelter, particularly the chronically homeless, people who meet that definition, have been unhoused for 12 months. I want to see those people get back on their feet and back into, so if we can help those people, that is, to me, the hugest victory. Whereas this is a shotgun approach right here. Everybody gets $10,000 if they can fill the form out correctly. I struggle with that. I really don't support that at all. But the targeted approach where here's a person demonstrated trauma of chronic homelessness, and they just need a few dollars to get them out of the shelter and into permanent housing.
I understand there's things that I struggle with this program, especially the high cost of rent. There's really no limit to, what people are paying. And so I do want to make sure that, we're getting people into a place of housing stability first. I do believe in that triage model. But with this discussion, definitely want to provide feedback to staff and direction to staff for any future updates on our strategic plan to address homelessness, to pursue any available opportunity for rapid rehousing funds. I think that's definitely clear here. And then making sure that future emergency rental assistance is further and further prioritized for those who are in most urgent circumstances. So I'm supportive of that as well. Are we able to move to the next item? Do you have any more comments on DHAT?
No, I don't.
Okay.
Okay, up next is an update on the Safe Parking Program with Ms. Nicole McCune, Safe Parking Director for Jewish Family Service.
Thank you for joining us.
Good morning. Thank you for having me, Mayor, Vice Mayor, and city staff. So for the month of August, on the last day of the month, we had 29 individuals enrolled, which comprised 22 households. In the month, we had 12 new individuals who we served, which comprised 6 households. And we had 2 residents of Vista re-enroll in the program. By age, we had 2 adults 18 to 54, 2 adults 55 and older enroll in the program, 6 adults, which comprise 50% of our new enrollments, being the ages of 18 to 54, and we had 4 minors enroll in the program. You can see zip codes prior to enrollment. We had 2 from the North County area, 2 from Vista, and 2 from other. We had, in the month of August, 8 total vehicle exits, or 10 individuals exited. Our breakdown is 3 unknowns, and so that was participants who staff were unable to get into contact with, so we don't know why they left or where they went to. We had 4 exits to permanent housing, and then 1 exit that was a negative exit. And you can see on the right there the number of individuals that composed those households. Since the inception of the program, we had 86 households exit. 21 of those were unknown exits. 4 were unable to be served. 13 positive exits to a family reunification. 3 that went to a hospital or medical facility, which could include a rehabilitation, skilled nursing, or a substance detox center. We had 17 exit to permanent housing, and then 7 to a shelter or a housing voucher program.
Could I ask a question on the positive exits? I
Sure.
see family reunification. That sounds like the person who's sleeping in their car goes back to living with family.
Yeah.
And how is that different from permanent housing?
So they are able to stay there for a long time, but they're not renting. They're able to stay there and work on their next steps, but they're not actually paying a rent.
Okay.
But it is a stable housing for the moment. And then 21 of those household exits were to a negative exit. And you can see on the right the number of individuals for that breakdown. And for the 4 people who exited to permanent housing this month, it took an average of 63 days in the program, so just a little over 2 months. Our average nightly occupancy was 19, and that came to a rate of 76%. And I will say that the hot weather in August did affect our occupancy rates.
And are we finding that people are looking for alternatives to sleeping in their car? Like maybe they're getting a hotel room during August because it's so hot?
Either that or they're staying coastal areas.
Okay.
It's cooler for them, or they are coming to the program later at night at 9 o'clock when it's dark and it's cooled down a little bit more.
Okay.
Yeah. And that concludes the presentation. If you have any questions.
Do you have any questions, Mayor?
So remind me what the dollar amount of our investment in this program is?
It's about $425 a year.
Okay. I'm curious, and I don't see it broken out here, and I'm struggling a little bit on the uptake from the numbers on this chart, but I'm looking through it. I'm kind of wanting to compare the cost of outcomes to the cost of other service providers and other kind of programs. And I realize it's apples to oranges because this one's people living in their cars. It would seem intuitively, maybe it's counterintuitive in reality, but it would seem intuitively it would be cheaper because we didn't have to maintain a building, although in reality, probably the staffing is the most expensive, and that probably doesn't change much. But I'm kind of curious to see how the money breaks down. Not that necessarily more expensive is not good, but sometimes it's helpful to know what the outcomes are on a per dollar basis. So I'd like to. I'm gonna follow up on that because it was my impression, and I might be wrong, that the outcomes were a little higher in expense. I don't know. I don't have a specific question, just that desire to pursue that line of inquiry.
Yep, maybe a budgetary breakdown for this program. And I had a question. So I see an average days to exit as 63. I think that the trend right now, from a little bit of data I was seeing from Regional Task Force, is that people are staying in any type of shelter service longer. And that is likely because it's more difficult and it's taking longer to find those permanent housing options. Are we finding that that's also the case with our safe parking program?
So we have a few different populations that we're serving. So we've got seniors who are over 55 on a fixed income, people with disabilities on a fixed income, and we are seeing them stay a lot longer. They're waiting for subsidies and matches. They're on low-income housing lists. We're doing diversion to see if they can live with a family member. They have a support network. Those folks, they can't really afford a market rate room rental because they're making like $1,100 a month. So with their expenses, their medical, their food, a room rental is about $12, $13, upwards to that. You can find it a little bit less expensive, but they don't have the income to sustain that on their own. So we are waiting with those folks for matches, for rapid rehousing, different options for them.
Okay.
But then we have a population that's more mobile. They're increasing their income. All of our participants are doing an assessment and budget, and so we're identifying barriers and then helping them remove those barriers to get it back into housing.
Okay, thank you for that feedback. I'm just, trying to look at our circumstances with the folks that are staying in our safe parking program, knowing that most all of them do need permanent housing, and there might be some creative solutions. And I appreciate your questions, Mayor, about programming costs, because I can imagine that that is a large portion of the cost, right? The infrastructure itself is not significant. But if we could transition folks that are staying in their cars into even a longer-term solution, like a micro cottage facility, right? That would kind of reduce the amount of programming that needs to exist because the infrastructure is more stable. So I would like to maybe work with staff a little bit more on transitioning folks out of this safe parking program faster, and seeing if there's maybe specific demographics like seniors, right, who are just really having a hard time exiting, and they might be the ones that are kind of dragging up that average, right, of what's taking longer because of their fixed income. So thanks for providing that information. It's something for us to think about.
And if we have, I just triggered a thought. I mean, we just gave a $500 million to National Corps. We should have extracted from them a contractual obligation to take people out of our safe parking and our navigation center who are seniors and would qualify. We should have made them have a preference to take those people first in exchange for that money. So what's the next senior housing that we're looking at?
Just so you know, that negotiation with National Corps happened before we had our
No, I'm aware.
Granite Creek Center online. So, but the next project we're working on is our project right here at Palm Drive that we're working with.
Do we have some of that outlined for seniors?
Yeah, I believe half the project is a senior project.
Yeah.
So we could do that as part of this project.
Yeah, I spoke to, with the Palm project, in the supportive housing units, getting folks out of safe parking in the shelter into those units and having a preference for that. But the seniors,
I think it's challenging because we know that there's also, as much as I want to respond to the seniors that are in our safe parking program, I will never forget a gentleman I worked with who, when I was providing services, he was sleeping in his car, and he basically had permanent disability and back damage because he was an older gentleman who was sleeping in just inappropriate situation in his vehicle, and it made his situation worse, right? But the same can be said for the folks that are immediately on the street. So, you know, I would look at, you know, any intervention for seniors is important, but I know that we do have a significant senior population in our safe parking program. So any future permanent supportive housing, it would be reasonable to accommodate some of the folks from our safe parking program.
That would be amazing.
or maybe just have, again, a chronic homelessness component to how many of those people in the seniors part of it are going to be. I'd like to have a discussion about that. We don't have to have it right now, but I'd like to know how many for chronically homeless seniors we would accommodate there.
Right, coming from both our safe parking and from our navigation center. Would be great.
Committee might be interested to know, so in particular with the National Core Development for Senior Santa Fe, the city's $500,000 is a relatively small contribution compared to the project-based vouchers that were paid through the county. So a lot of them were paid by No Place Like Home and through the VA. So the majority of those units, in fact, all of them are reserved based on those project-based vouchers. But for the Wakelet project that we've been discussing that is coming online very soon, we should have some more flexibility since the city's contribution is much more substantial.
You know, and we gave them $500,000 because they asked. They were already fully underway, and they said, would you want to contribute? And we said, you know, out of the kindness of our hearts, sure. My point is, we shouldn't invest in it. I mean, that was the way it worked, was it not?
Some benefits out of them. They put some bus stations in, they did some street improvements, they repaved a portion of the street in front of the project. I mean,
Well, that's good, but I just mean to say that it was happening whether we contributed or not.
100%.
Yeah, so we didn't need to, so it sounds like we washed some housing dollars for some street improvements.
You could call it that, but
Okay.
yeah, we got public benefit out of the dollars.
We got public benefit. My point is, I'm frustrated that, sorry, I didn't mean to paint it in pejorative light. My frustration is that all of this, and this is something else that doesn't get talked about, all of this subsidized housing, it's not serving the people who are in the greatest need. It's more accessible to people who are in lesser need and can wait 7 years on a list to get into it. But imagine a world where the people who are actually homeless got first access to the housing. Right? Game changer. We do it the exact opposite. Almost all of the housing that's subsidized is much more inaccessible to those people, and it's accessible to people who have put their name on a list and in many cases have waited for years to have access, or they're in a place with AMI. So I just think we need to be cognizant of that and try to get housing for those people who, without it, are actually living on our street. Not we say they will be, we've observed it, and they're known to be chronically homeless.
Mayor, I'll be happy to know that that is an important and fundamental feature of permanent supportive housing is that they are placed for individuals who are experiencing homelessness and are entered into HMIS through the CES system. So all of the individuals placed into PSH will be individuals experiencing homelessness.
Right, and I asked to have a certain number of PSH units in that development that were at Palm.
Yes.
And I don't remember what it is right now. Did we come up with a number? Was it going to be 10 or 20?
They will all be PSH.
All 100 and...
Over the two properties, yeah. Or the two
They all
properties of
are.
permanent supportive housing. One of them restricted for seniors, but 100% of the units, aside from the manager units, will be PSH.
I think we were talking about having a higher level of PSH for these people recovering from chronic homelessness. That's what I'm referring to. What's that? Yeah. Well, isn't that what
services.
Affordable
PSH
housing
is?
does come with those wraparound services to assist those transitioning from homelessness.
How many of the units?
100% of them. It's the number of units is still being negotiated, but right now it's roughly about 120, 130 that's being proposed.
Mayor, I believe the conversations that, in my recollection, one of the biggest things that we want to have oversight on in this PSH is really who's being served, right? And so we've had that about like local discussions about like local service.
Can I interject? These were closed sessions discussions, so we shouldn't be airing out.
Thank you, Walter. We will move forward to Alliance Shelter Beds. Thank you for your updates on safe parking.
Okay, up next is an update on the Alliance Shelter Beds. As the council may recall, this contract was approved last year at the end of September. And through July 2024, a total of 78 Vista residents were sheltered at the Alliance Network. 16 of those at Haven House, 14 at La Posada, 28 at Operation Hope, 1 at the Interfaith Rotational Shelter Network, and 19 at the New Escondido Family Shelter. You'll see a graph on the right of the different referral sources for those residents being sheltered at the network, with the majority of those coming from Excess Recovery at 32. You'll see a breakdown there of the age range of the residents sheltered at the network shelters. 33 of them adults, 18 through 54, 27 youth under 18, and 18 older adults, 55 years or better. Length of stay for the 59 clients there, you'll see a 28 over 120 days, 30 to 59 days at 17 clients, and a various distribution of the other lengths of stay. There were 59 total clients exited from the network. 18 of those found permanent housing. 14 were moved to a different program. 13 moved back to a place not meant for human habitation, and 15 unknown exits. Of the program clients that moved to different programs, 5 went to a recuperative care program, 2 to substance use program, 3 moved to a different shelter, and 4 to transitional housing. Reasons for negative exit included 5 clients who violated program rules and 7 for self-exit. Any questions on the Alliance Shelter Beds?
There is quite a bit of shuffling people around. That's all I'll say. Mayor, any comments?
Yeah, my question is, because we have stopped utilizing the Alliance shelter beds as heavily, and this is data that encompasses 9 months into July 2024. What do we have for August or even July as a single month so that we could understand what the current rate of utilization is?
We have individual reports. We can provide that to you.
Okay. But basically, we are not using,
We are.
we are still?
Yeah, so you'll see here a total of 78 Vista residents sheltered within the shelter network over the course of 9 months.
Yeah.
So we do continue to utilize them and rely on their shelter beds outside of the BCNC.
This encompasses,
Majority of the program year, yeah.
this encompasses 3 months only that BCNC was operational.
That's true, yes.
So my understanding is that we're utilizing the Alliance beds less now. So yeah, I'm very curious to know, now that BCNC is online, what is our utilization of the Alliance shelter beds? So if you would give me the current utilization numbers, I'd be very interested to know.
Absolutely. Any other questions on the Alliance shelter beds? Thank you. Next up will be the BC.
My question is, what was the date that we went to a per diem reimbursement rate model?
September 26th, 2023.
So that's most of this period. So,
Yes, the entire period.
so what was our actual cost per bed night?
I don't have those in front of me, but we did hit the contract ceiling in January, so it was very quick.
And what did we set as the ceiling again?
200,000.
So we still wound up spending, because we had 10 beds times 200, 20,000 apiece. So we still wound up spending We hit that in January. I wanted to make sure they didn't, they weren't taking our people before we did that. They were rejecting them, and they weren't telling us they were rejecting them. And then all of a sudden, when we attached the dollar to making a bed available, surprisingly, beds became available very quickly. So I'm not surprised that we ran out of the money. But I guess it's better that we spent money and got a service than we spent money and didn't get a service, which was what was happening before. I just want to make that point.
Yeah, I think that's fair to say. I think overall, we're seeing roughly the same amount of Vista residents being housed. This includes, as you'll see, all the different referrals from different providers, not just the contracted outreach provider of Exodus. It did previously also, but the issue that the city council had was that the Exodus referrals specifically were not being prioritized.
Right.
But the actual utilization turns out to be roughly the same.
Now, I remember Haven House was coming in at over 120 a night. La Posada was like half of that.
Off the top of my head, yeah, Haven House was.
Not right now, but I'd like to review those reimbursement rates going forward and dive just briefly into this subject again, because it is a supplemental resource for us, and I want to make sure we're getting a fair deal.
In fact, this will be coming back to City Council for a renewal of the contract on October 8th. I can provide those reports ahead of time for your review.
Yes, definitely.
Absolutely. Any other questions?
No.
Thank you. Up next is the BCNC. Nanette Steenstra will provide an update on the Buena Creek Navigation Center.
Good morning. So we will start with the month of August. Looking at intakes, we had 18 intakes at the BCNC for the month of August. Half of those were through Exodus, and then the other half were through other referral agencies, including PATH and Alpha. Almost 3/4 of these intakes had a most recent living situation of a place not meant for human habitation. Other living situations were a hotel, housing a lease, so living with family, or other living situation that was not permanent, a hospital or a substance use treatment center, or another emergency shelter. And then you can see that over half of these individuals had been homeless for 6 months or longer.
I have a question for you. Would it be possible to ask folks, the place not meant for human habitation, could we put how many were living in their car? Just get a little bit more, I don't know what would be appropriate to ask and record, but, living in an encampment, is that something that would be appropriate to ask? It would be really interesting to know. And, one of my purposes is to get people out of encampments and into the shelter, and then shortly thereafter into permanent housing. So it would be really interesting to know. And I know that place not meant for human habitation is supposed to be synonymous with encampment, but it also encompasses living in vehicle. So definitely at the minimum, I'd like to break out living in a vehicle if we can.
Yeah, we do ask for a detailed description of where the client came from. So they tell us if they were living in their car, if they were living in an encampment, maybe what area they came from. And so I can definitely provide that data to you.
From your experience with this population that you've served in the last 6 months, are there other situations that would be a reasonably unique category from, we have encampment, we have live in car. Is there anything else that you could imagine or describe based on the people that we've served that is encompassed by place not meant for human habitation? Or is it pretty much, to your experience, almost exclusively those two situations?
I would say primarily those two. The other locations that are listed are also not long-term housing situations. So they're meant for habitation, but not long-term. But that is, of course, we specify those categories. I don't know if Daniel has experience with outreach. Maybe he could specify.
Other areas we find people living in are abandoned buildings and RVs that don't operate.
RVs, RV would be a good category. You're living in an abandoned building is pretty similar to encampment. It's a little bit better than living unsheltered, physically unsheltered, to get really specific with these terms. But I think you've got great specificity on the places meant for human habitation, but not for permanent habitation. A little bit, just maybe one or two or three more categories of they were in a car, they were in an RV, they were in an encampment. If you can break any of that out, the more detail, the better. Really helps us understand where the flow, where are these people coming from?
I would support that, and I would be curious, I don't know if we need to add it to the data set, but I would be curious about the type of encampment, right? So when we refer to encampment, we're probably referring to someone who is camping outside. That could be with a large group of people. It could be as an individual with no like overhead shelter like a tent. It could be a single sleeping bag on the ground. But it would be interesting to know of the folks that are camping as their means of sleeping outside. What does that look like, right? Is it with a group? Is it an individual sleeping bag? That it's probably too much data to collect right now, but that's just piques my curiosity in this conversation.
Yeah, we can certainly collect that in the future. And then in the month of August, we had 21 exits, with 38% of those going into permanent housing. So 6 of those permanent housing situations were rentals without subsidies. And then we had 2 clients that entered into a rental with a subsidy. We had 1 client enter into a temporary housing situation, which was a hotel, 1 that entered into an institutional situation, which was a hospital. And then we had 11 clients who returned to a homeless situation. 8 of those were exited by staff due to behavioral reasons or reaching their time limit at the BCNC. And then 3 of those clients chose to leave upon their own accord.
And I would just point out that we have not hard imposed a time limit on the length of stay, but we've empowered the shelter staff to make a determination about whether people are working with intent to progress towards permanent housing. And it's our understanding as a council that you have a time limit at which you will say, look, we've given you this. What is that length of time, generally speaking?
So we extend by 30 days up to 120 days, but we do have flexibility. So we have had clients stay more than 120 days, but they need to have a specific plan of where they're going next.
So it's 30 to 120 days?
Correct.
So, and those are sort of rolling limits that you impose where if people are not clearly interested in working a plan, if they're not going to make some voluntary, and they're working with a housing navigator and a case manager, but if they're not expressing an interest in the help that we're offering, then at some point we have to say we've done everything we can and you're not taking positive steps. Those would be people that have in my opinion, grave disability because they were homeless chronically. We've done everything that we could think to do to help them, and they just don't want to be rehoused. What do we do if somebody lacks the ability or desire to take basic steps? It would be super helpful if you could tell us the stories of those 3 people or the people that you had to exit not for behavioral issues, but you had to exit them because they just, weren't making the progress. What happened with those people? It would be really interesting to know.
Yeah, well, so those 3 clients that exited, that was completely their decision.
Right.
Realistically, they're not probably engaging in case management services, so.
But the 8 that you had to exit, were all 8 of those because their behavioral issues represented an antisocial environment or a dangerous environment to the other clients?
Yeah, that's correct. So anything like aggressiveness, violence, threats of violence, substance use on property, those are most of the 7 exits back to a homeless situation.
So we didn't put anybody out on the street because they weren't making acceptable progress.
We had one client who went to a different emergency shelter, and that was because he reached his 120, excuse me, his 120-day limit and was unwilling to make any steps forward. He was content with living in a shelter, and so he moved to a different shelter.
See, that would be really interesting, again, without breaching any confidentiality. I'd just love to understand what things were asked of that individual. What was that person asked to do that he or she was unable or unwilling to do? That would be, I'd love to understand that.
Yeah, he was an older gentleman who had limited income and was asked to search for housing and find a more permanent solution, and was just unwilling to do so.
When you say he was asked to search, the staff at the Navigation Center was helping him with that search, right?
Correct, yeah. His case manager was very involved with his case.
Was that because he would have had to use his limited income to pay for?
Well, so he was an immigrant, and it's a pretty complex client, actually. He was an immigrant, and he was waiting to get his immigration status so that he could, if he wanted, he could return back to Mexico. But at the time, he was unable to go between countries because he was waiting on that. And yeah, so that presented a large barrier for him.
Interesting. Okay, that's illuminating. Thank you.
Yeah. So our next slide, we have the services and referrals that were provided in the month of August. In August, we had 54 active clients, so that includes all the clients that were served, that were intaked and exited, and were active throughout the month of August. So you can see the list of services provided by staff. So this is any service that's provided by our case managers or any other retread staff. That includes transportation services. We have a weekly shuttle service that will bring clients to the DMV or to the Social Security office or any other locations that they need to be transported to. We also provide bus passes if clients have a specific place that they need to go to, including work or school, the library, things like that. So that's the highest number of clients that were served. And this is not specific, this is not 42 clients were served, but there were 42 instances of that service provided. Other services provided were Social Security assistance, a VI SPDAT, which I think we've talked about previously, but that is the vulnerability assessment tool that's used by HMIS, employment assistance, cell phone, resume building, mental health assistance, housing assistance, and then Social Security assistance as well.
Have you been able to complete a VI SPDAT with every resident?
We make it a goal that every resident either comes in with a VI SPDAT or we complete that with them. Some residents refuse to meet with case management, so we won't have an opportunity to do the VI SPDAT with them because it's a pretty extensive assessment tool.
Now, if somebody refuses to meet with their case manager, is that a reason that they would be exited?
Realistically, those clients don't stay very long.
Right, okay.
Yeah.
I also noticed that I don't see the dental in the contract volunteer services. Wasn't VCC going to provide dental?
Yeah, they didn't
Just
come
hasn't
this
yet?
month.
Okay,
Yeah.
all right, very good.
Yeah, so we can move on to the contract volunteer services. So this is any external service provider that's coming on site to provide services to our clients. So barber/personal care. We have Abellis Academy students come and they provide haircuts and manicures. And then we also have another barber who comes. It's a very fun event. And then we have a homeless court advocate who comes, mental health services, so that's going to be Turn. and then primary care doctor, which was VCC. We also offer on-site classes, so there you can see our class attendance. We provide classes every single day or some sort of recreational activity for our clients. And then the last graph, you can see the services that were referred by our case managers. And then on the left side, we had one job placement for a Vista client in August, and then 2 clients who got matched to a housing subsidy in the month of August. And then the last page is our year-to-date outcomes. So this is through August 31st. We have served 115 Vista clients, and 2 of those clients were return clients. We had 82 clients exit the program from its inception to August 31st. And then the bottom graph shows the exit destinations of all those 82 clients, which is 34% have exited into permanent housing situations. And then you can also see the amount of time before exit to permanent housing in both a graph and an average. And in the bottom right is the housing subsidies that our clients have been matched with.
When I came to, oh, I'm sorry.
Oh, please.
When I came to visit and ask you some questions, one of the things I asked was how many days total of operation since inception, how many days at full capacity, and at that time you had data for 163 days and you'd been at full capacity for 5 of those 163 days. When you present on a regular basis, I'd like to know since inception and for the last quarter, the last whatever period you're reporting, probably for the last quarter, how many days were you at full capacity, were not able to accept referrals? Because I want to start digging into and hold accountable everybody, Exodus, Mr. Sturman and Mr. Lung, and the BCNC. And I know right now you are not in charge of who's being referred to you. The BCNC is not. But I want to understand specifically, I want to know, I had deputies report that they had referred people that didn't get in. If Exodus is referring people that aren't getting in, I want to know, and I'll take the time, if you will, I want to hear the story of every person that got referred that we were not able to accommodate. And I want to know why we couldn't accommodate that person and what we need to do, because it really bothered our deputies that they had referred people, and they expressed to me that they felt that it wasn't sincere when we said that, we're asking them to clear encampments, and they felt like there really wasn't an ability to get people in. And that bothered me a lot, that our deputies felt that way. And so I want specifics of every decline. Anytime somebody, sheriff's deputy, Exodus, I don't care who it is, if there's somebody in Vista that said, I want to go, and we couldn't accommodate them, I would like to have a detailed review of circumstances in these hearings. I don't think there's that many of those, but our job is to figure out why we couldn't serve that person and understand if there were things that we could do differently. Is it capacity? Do we in fact need more capacity? Are there policies we need to change? Or was it just a set of circumstances that no good intentioned, well-funded organization could solve? That's fine, but we need to know and have review and have accountability for that.
I'm supportive of receiving more of that information, and thank you, Nanette, for providing these updates. I'm really impressed with what we're able to do in this setting. It sounds like people are given the best possible opportunity at recovery, and I continue to see that there's gaps in services, but that's not our shelter staff's fault necessarily. It's on our decision makers to identify what are the most pressing needs. And there may be circumstances where people are denied an opportunity for shelter in the moment, but as much as possible, I want to expedite their entrance into the shelter. So I'm supportive in seeing how can we overcome that. We are managing those referrals in-house. Is that right, Daniel? They're going through your office. I think that oversight's really important. Rather than just coming from all over, we're able to funnel them directly and transition them smoothly. And there is some time in that transition. So would you have any ability to speak on that now, or is that something where you can bring back some information to us?
Just really quickly, as we're sitting here, I'm trying to coordinate some intakes. For example, today we only have female beds available. So I've had people reaching out to me regarding a male intake, and we just can't service them because we have 2 beds available on our female floor. So, but we can definitely get you data on why people aren't being accepted the day they're being referred.
And we have 12 female beds.
That is correct.
Okay. Is there co-ed in other parts?
The rest of the 3 buildings are, or the rest of the 3 floors are co-ed.
Okay.
Do we find regularly that the female beds are unoccupied? Not particularly.
No, I don't think there's any overwhelming noticing that.
Okay, just for today. All right, that's good to know. All right, thank you. I think that brings us to our last slide here. Anything else on general homelessness updates, Mayor?
And you said, okay, so you said only female beds are available right now. Okay, all right. I just did the math on it. Looks like the number I calculated 44 successful exits of the 82. That sound right? So that puts us at 53.65% successful exit. That's great. Those are very good numbers. How about our regional people from GFS? That's pretty good numbers, right? Your numbers are pretty good. What was your successful exits number? I don't have it off the top of my head, but I want to say it's like 35. Yeah, no, those are good numbers. Those are much better numbers than we saw coming out of the Alliance shelter.
And I think, Mayor, this really is, I'm motivated to share this point because of our last discussion about the capacity, a smaller capacity being more challenging for financing, yet being more effective for the outcomes that we want to see. So it really is a delicate balance of having a more home-like setting. I think we're seeing is more and more we're seeing is the effective way to go. But as our next discussion item, we're coming up to regarding our permanent shelter options. We're going to see where we strike the balance with the shelter structure and what our potential facility could look like. So moving on to item D2, moving back really, just checking in, do we have any members of the public who wish to speak?
No speakers.
All righty, one day they'll come. We'll turn it over to Management Analyst Daniel Sternum to provide the staff report for our permanent shelter options.
Good morning, Deputy Mayor and Mayor. Glad to be here today discussing the next step for Vista's permanent shelter. So today's staff will be presenting for you some initial concepts to take into consideration as the City of Vista initiates its intent to build a city-owned space to support unsheltered individuals. The discussion is meant to provide staff with direction on how the city would like to design and construct its first permanent shelter. Based off the feedback provided today, staff will move forward with a deeper investigation and more accurate costs and timelines for the completed project. The information provided today is very preliminary. Based on parameters received from Council, we will return to City Council with a proposed plan and feasibility study. I'm going to provide a list of some considerations to take into account when choosing a location. Transportation. One is being close enough to a major transit hub. The current situation with the BCNC is optimal as it has a train and bus station very nearby. Another consideration to take into account is adequate parking for staff and clients. We have struggled at times at the BCNC for parking for clients as our parking is limited in the back for them. Another consideration to take into account is that it takes about 10,000 square feet to provide semi or non-congregate shelter with restrooms, shower, and laundry services. This does not include space for parking, offices, a large multi-purpose room or computer or classroom space, and a kitchen at a minimum. Optional space for auxiliary areas such as medical buildings, a dog run, or a smoking area are also not included. And the last consideration I'd like to bring for you today is a proximity to the community. Is this location close to job opportunities for people, or are they going to have a burden in transportation to get places like jobs, physical mental health care, and quality of life activities such as church, gym, and other things? Another topic to consider is the location and proximity to services that businesses that service minors, so things like schools, daycares, and recreational businesses. On occasion, shelters do serve individuals with a PC 290 designation, and this may prevent those individuals from being able to utilize that facility. Here are some options to consider when deciding what type of structure we will be utilizing. The first is an adaptive reuse. This utilizes pre-existing structures and modifying it to be used as an emergency shelter. We can both utilize City of Vista-owned properties or purchase a new property. Potential savings in time and money due to utilities being on site, pre-existing structures on site, and other existing infrastructure. Although this is an option to consider, staff has not been able to investigate much due to the high amount of variables involved. The other option is purchasing raw land. Starting Fresh would offer the City of Vista the ability to create their navigation center to their exact specifications. Depending on the state of land, time and cost of the project can greatly vary. And on this raw land, we would probably be building modular construction. Modular construction is a process in which a building is constructed off-site under controlled plant conditions, using the same materials and designing to the same codes and standards as a conventionally built home, often built in half the time. Buildings are produced in modules that are transported to and put together on site to create a larger structure. Depending on the material and design chosen, these structures can last 20 to 50 years and beyond. We'll be looking at 3 different styles of modular construction today. The first is a designer called Connect Homes. You'll see an example. The pictures on the bottom left is an actual unit they recently built, and that was built in the Victorville Wellness Center. It's a 4.5-acre city-owned property that provides 170 beds to accommodate men, women, and families. The top picture you see there are certain layouts that they've provided and some costs.
How many beds did you say?
The Victorville Wellness Center is 170 beds. They can create semi or non-congregate options as seen in the top left corner.
Do we know what they spent for construction costs?
We do not, but I can work on trying to obtain that. They utilize a modern design and use the same materials that they use to build high-end homes. It is a steel frame construction. This has a very long lifespan, costs about $25,000 a door or a bed to build. One of the issues that we kind of saw is that we will have to contract out for certain things such as a communal kitchen and communal bathrooms. And the rendering you see at the bottom right, that's a rendering showing something they would like to build. Because they are HCD certified, they can build on top of each other and immediately next to each other.
How many stories high can they go?
I believe it's just 2. Mm-hmm. Here you'll see LifeArc. The bottom right-hand corner is a project they already have operational in the County of Los Angeles. LifeArc is extremely customizable. They can produce semi or non-concrete options. They utilize recycled plastic to build their units. They do have a long lifespan. They come in 8-foot by 8-foot little modules that get pieced together to make a larger structure. They can provide all the structures and provide project management. They cost roughly about $25,000 a module to build. I do want to note that because of our housing regulations here, we might have to use 1.5 modules per person for a non-congregate shelter. The image you see on the left, LifeArc put together a design to possibly utilize a current property the City of Vista owns, which is North County Lifeline. We requested that they do a quick study to see if we can put enough beds, 48 beds, within one of the parking lots. And as you can see there, they have managed to produce something that would
Sorry, Daniel, I had one question. You mentioned we had to have 1.5 potential units because of our, can you expand on that, our housing requirement?
Yeah, so many of these modular constructions were built for communities that operate under an emergency declaration, which reduces the minimum residential floor size that's required. Since the city of Vista is not operating under an emergency declaration, we do have to abide by the minimum California building code, yep, which would be 1.5 units.
Going back to it, they produced a design that would show that we could utilize the parking lot at North County Lifeline just for the sheltering opportunities. I do not believe that includes offices for staff meeting with staff, sorry. North County Lifeline does have a large open space that could, and they have a kitchen in there. It would probably need some remodeling, but that's for direction from council. Last we'll be looking at is Mobile Modular. Mobile Modular is proud to announce that they already use Sourcewell for their procurement process, which the City of Vista also utilizes. They designed a semi-congregate arrangement that you'll see at the top left corner. Each room has 2 beds, a desk, and a closet. This utilizes traditional modular construction, so wood on a mobile frame. They also have a long lifespan, roughly $54,000 a bed to build. They can provide the full range of project services and management services. This company is a nationwide and has extensive experience in producing a wide variety of modular projects. And that is a presentation that I have for you today.
Thank you. I have a couple questions. So I appreciate the option of the modular building. Why that versus a different type of construction?
A traditional stick build will probably cost significantly more. Due to contractual agreements, we have to pay prevailing wages, so every employee that's physically building the on-site house would be getting prevailing wages, as opposed to if we bought a modular unit, we'd be buying a product, and the only people that we would be paying prevailing wages to are the people actually installing the project.
Okay. Understandable. My concern is this emergency declaration. Jonathan, you and I were in a meeting, and Imelda as well, with Senator Blake Spear and an expert on this topic, and still learning more about the types of options that we have under an emergency declaration. You know, I'd say that the community and our whole council could agree that the situation with homelessness in our community continues to be an emergency. And our ability to provide shelter depends on the regulations that are currently in place. So I would be very interested in our city moving forward with an emergency declaration. But I want to know a little bit more. Jonathan, if we were to have an emergency declaration, how would that assist us in this opportunity to provide shelter, and how would that expand our options?
Yeah, specifically regarding the procurement or acquisition or building of a shelter, there's a section in the California Building Code, Appendix P, which allows communities that are operating under an emergency declaration of an emergency shelter bed shortage to be able to reduce the minimum floor size of a residential unit. I believe it allows as small as 7 by 7, whereas the California Building Code allows something like 1.5 times that. So we'd be able to build smaller units under the emergency declaration.
Well, I'm favorable to that because this is not an opportunity for a luxury development, whether it's modular or not. This is an emergency where, as quickly and efficiently and with greatest cost savings to the taxpayer, we should be providing shelter. Also considering that many of these constructions, you know, the lowest time that you mentioned was 20 years, that's not too long in the whole scheme of things. And so I feel like this type of construction would be appropriate for our city on an emergency basis. So in order to have that discussion and utilize that potential of an emergency declaration, I would ask city manager to add that to discussion for an upcoming council meeting prior to reviewing the Gen 2 Navigation Center with the whole of the council, because as our whole council reviews potential navigation centers for future permanent builds, I want to make sure we have all of our options. And I believe an emergency declaration would allow us to do that. And perhaps it is not appropriate, but I believe it's time to have that conversation. And as much as we are doing to address homelessness, the urgency is still there, especially when it comes to those material needs of the actual shelter and housing units and beds for people. As we saw in all the data that you presented to us at the previous item, we are getting a good amount of referrals. And I do believe when we have more options available, they will certainly be at or close to capacity as well. So that would be my point of feedback for this. Outside of the emergency declaration, I really do like adaptive reuse. Does the emergency declaration speak to adaptive reuse at all?
Not necessarily, unless we were considering how we build individual units within some commercial building or whatever other building we're adaptively reusing.
So it really would only be if we're building something new that the city would benefit at all from taking that stand and making an emergency declaration. But do we have any recommendations from staff on currently owned city buildings that would be appropriate for adaptive reuse?
Not currently. We also haven't spent too much time. We want to get some direction from the committee before we look too deep into it. A couple things to consider is that with an adaptive reuse, we generally won't be able to utilize like large open spaces like warehouses, or for example, the Burlington Coat Factory is a good example of a building that isn't very conducive to adaptive reuse. So outside of those, we haven't identified too many, but we also haven't started looking too hard either. So with your direction, we will look more into that.
Well, I think it's wonderful that we've been providing shelter in this short 3-year term, but we know that those resources are going to go away soon, and shelter will continue to be a need, and homelessness will continue to be an emergency in our community. So I would like to make an emergency declaration to allow us more options for shelter in Vista. Mayor?
We looked at these pallet shelters. You and I talked about that a couple of years ago, and we kind of came to the analysis that they're not, there's no question they're a cheaper way to build a building, but they don't necessarily make the most efficient use of the very expensive resource, which is the land. The sewer, grading, electrical, and other utility improvements are fairly well the same cost, whether you build a regular building or you build a pallet shelter or a pre-manufactured building. Those can be significant parts of the development. So the other really super important thing is the ability to go vertical. If you're going to be able to make maximum use of the land, then you need to have maximum density and be able to go vertical. And being limited to two stories, I think, is a real limitation. I know that you've been down and you've been through the Urban Street Angels facility. I think that's ideal because it looks like a college dormitory, 2 people to a room, and they had a few single rooms that people could earn their way into as a privilege if they were doing the right things and making the right progress. And then they had a gang restroom facility at the end of each floor. I think on either end they had one for women and one for men. I don't remember the exact layout, but that's a good model, in my opinion, to have a smallish room with 2 beds that's really for sleeping, shared restroom facility, some other part. You need a kitchen facility for these people. Although I don't know, maybe the contract kitchen works, but I think probably it's, if you're going to have 50 people living somewhere, I think probably you need a kitchen for them. This issue of not being able to use the gas stoves at the current facility, I mean, if people want to be able to cook, I don't know if they could do that if we had a kitchen, if there'd be some hours that would be supervised that they could use the cooking apparatus, just always trying to chip away at all the reasons why people tell us, that they don't want to go. And that was one of the things I heard. I want to make sure that I put this out there. I don't know if any of the other council members are going to agree with me on this, but I know that the people of Encinitas want to accommodate their homeless population in Encinitas and want to build a shelter there in Encinitas. And I know that Mr. Sturman wants us to increase the population. We could immediately gain 12 more Vista beds if let's say we stay right where we are, which is a very viable option, might be the best option. Although I'm very much interested in the long-term acquisition. I mean, it's better to own than to buy, than to rent, right? But in this case, maybe it is and maybe it isn't. I think we need to do an analysis of that. I like to have Mike Sylvia do that, and I don't mean to hire Shane to do 1,000 parallel
The
universes.
analysis has to be based on a time frame of when you expect. So, I mean, we have to build in how long we expect to have this shelter in operation. Okay, so do you have an idea of how long it'll be?
Why don't you start with a decade?
Okay,
Yeah.
some different scenarios.
Why don't you do 10 and 30 years? After 30 years, we would expect to have major, reinvestment of capital to basically renovate the facility. I think but I don't want to hire Shane at $500,000 to do the analysis with 1,000 parallel universes. I could do the analysis. I've got Microsoft Excel, and you give Joe Green and I Microsoft Excel in 2 hours, we'll bang this thing out. We'll tell you exactly what it'll cost. I don't want to deprive the people of Encinitas the opportunity to serve their homeless population in Encinitas. So I won't be supporting a partnership where we're importing people from any other location. My belief is this: we should accommodate the people who are willing and needing of shelter in Vista. And I know that Encinitas wants to do that in Encinitas. Escondido wants to do that for Escondido's residents. And every city should build an appropriate number of shelter beds to shelter their population without moving people around. Because as has been said this morning, if you have to take people out of their community to shelter them, that's not the best thing for them. So I don't want to be importing people to Vista and denying them the opportunity, because we made an easy pathway for another municipality. I'm not saying this about Encinitas, but I don't want the people from any other city to have an out to go, well, Vista will take them. We want to serve Vista's population. That's our job to do, and the other councils of the other cities to serve their population. So I just want to lay that out. I want to start laying the foundation for we're all going to be agreed on that. They need to have a plan, and I hope that you're talking to Steve, and I'll talk to Mayor Kranz, and we all need to be talking to our colleagues over there. What are you going to do? Because what do we have? 2 years and how many months left?
The end of 2026, so.
We have 2 years and 6 months, or we have less than that now?
Less than that, yeah.
Yeah. So I just like to see it costed out. What would it cost to do like a concrete tilt up with a similar design, maybe go 3 stories, maybe go 4. Again, how do we efficiently use the land? What's the cheapest option to provide? We love, I think we would all want to maintain as much of the residential charm, I'm going to call it, of the current navigation center. I think we all feel that's important, right? We want to be proud. But, the Urban Street Angels facility, that was a clean, serviceable place that was much better than being homeless. The cinder block walls are not nearly as homey as drywall, but what is efficient? And like you said, we don't want to spend $1 million a unit. We don't want to spend $500,000 a bed. We want to spend $110,000 a bed or something reasonable to get there. So,
And if I could add to that, Mayor, I do support what you're describing, highest possible use of any land that we use. And having to pay prevailing wage for that is understandable, but we get a more permanent product. And think about the opportunity for us to then potentially convert the city facility into workforce housing, right? If you're referring to dormitory style housing, it doesn't need to be permanently used for a shelter, depending on what our needs are. And we're continuing to update our strategic plan to address homelessness. So the benefit of a more permanent, stable, attractive city facility is for many reasons.
Now, can we take a loan out of other funds? Like, can we take a loan from our housing? I mean, we could probably use our housing fund to pay for this, but can we take a loan from a housing fund, or can we take a loan from any of our internal funds?
Sure.
I mean, if we needed to spend $15 million instead of
We
$5,
can use whatever we want as long as it's available and we're going to reimburse it.
yeah.
Yeah, as long as the money is eligible for the use, of course.
Mm-hmm.
I wanted to clear one issue, and that is the way we're pursuing this in terms of feasibility and looking for sites is we're looking at city properties that
Right.
we own first,
Sure.
determining what's feasible in terms of what we could
Smart.
put on it, and then we'll look at commercially available properties following that. So if you guys are okay with that, that's how we'll follow up.
Yeah, I
And
think
we'll do
that's,
the financial analysis too of the existing facility and the rental scenario.
yeah, I think that's smart. We should look at all the options. It's a big project, and obviously you start with the land you already own first. I think the location has actually been pretty favorable. I like the idea of getting people. I feel like we've gotten a little away from that urban core where maybe they're, I feel like it's a little bit of a respite where they're at right now, but still very near transit, and they can get where they need to go. Those are all the thoughts I have. I'm not in love with the look of the temporary stuff, and if it really actually pencils out that it's better, then I'm okay considering it. But I also want to pencil it out over 30 years because the city isn't going anywhere in 30 years. We're still going to be here, and most likely, unfortunately, we're still going to have this need in 30 years. So,
And Mayor, did you have any thoughts on the emergency declaration? And I'll add one more point to support that, is that if we initiate an emergency declaration, then we benefit from those modifications to the code. And it doesn't mean that the structure won't still be standing, right, 50 years from now.
yeah. Well, I'm very much okay with the smaller unit size because, again, this is right now were we at 53 days? I saw we were at 42 and a half when I came to visit with Nanette. So we've grown a little bit in the average, but some time has gone by and we're still new. We don't want, this is not a place for people to live for, 120 days is the maximum. So it doesn't need to necessarily be spacious. It needs to be suitable to the purpose and comfortable enough, but we don't want people to see it as a place where they should make themselves comfortable. We want them to be safe, warm, reasonably comfortable, but we don't want them to say, oh, this is a place I'm going to make a long-term stay out of, because that's not the purpose of it.
We even have the opportunity to, have some units with an emergency declaration. We can have some units be at that smaller scale and other units be larger that might be appropriate for families, right? Or just having a different option for people.
So Patrick Johnson had some concerns about the emergency declaration that he shared with me a few years ago, and they were pretty valid concerns, and I don't remember what they were, but they were sufficient at the time to cause me to, and Mr. Connolly is...
Now, there are some implications to the declaration that we need to look into, but when we report back, we'll make sure that we disclose all those implications for sure.
I can't remember what those unintended consequences were, but they were some significant impacts that we felt would, on the whole, not, and basically after we examined the impacts, we decided not to bring it.
I just want to make one other point for the council or the committee to consider as well regarding the emergency declaration. If the intent of the council and the committee is to continue with double occupancy, it wouldn't be feasible to pass an emergency declaration. The units would be too small for double occupancy. So if there is some other consideration aside from cost,
If we do emergency declaration, then we cannot do double occupancy?
it wouldn't be feasible. You couldn't fit two bids in there. Yeah. So if the intention is to continue with double occupancy, the emergency declaration probably wouldn't have any additional benefit.
Well, double occupancy is a much better, more effective use of the space, even to have a larger, even if the unit is 50% larger, but you put two people in it, versus having two units that are smaller, but they're 50% larger together, right? So, and then I think we should have some rooms that are built for just one person, because there's some people, the only way we're gonna be able to help them is if they have a solo, right?
Right, and so under the emergency declaration, would we be allowed to have a mix of rooms where some are larger and allow for two occupants and the other are for single?
It doesn't require smaller units, but allows them.
Okay.
Yeah.
Okay.
What you said and what you meant is, if we utilize the minimum for floor space that is allowable by the emergency declaration, then the unit would be so small that two people in that unit would not then be feasible.
It's
Correct.
something for us to consider.
Right. So essentially, if we really do the mathematics on it, probably we get the best utilization of floor space by having two people in a larger bedroom. But then we can have some bedrooms for people that really need to have, and then occasionally we outfit them just like we do now, all for double occupancy. But then sometimes we have, a woman came in with two children. We pulled a bed out. We made a three-bedroom. We made a three-bedroom, and we accommodated. And then sometimes we have a two-bedroom that only has one person because that person needs, for whatever reason, maybe they snore or something. So I think we need maximum flexibility for the operator, right?
And I do appreciate any information staff can bring back on an emergency declaration. It's beyond cost. It's about being able to be as flexible with our needs as possible. And we've been, putting in a lot of hours, Mayor, you and I, in these standing committee meetings to review our strategic plan and to prepare for our next steps. So I want to make sure that what we bring to the council allows us the fullest breadth of options. And so I see that we would need to at least have a discussion about emergency declaration before moving forward with Gen 2 Navigation Center with the whole council.
Would you be amenable to discussing the emergency declaration here at the committee level again before we take it to the council?
I'm not opposed to that, but in terms of staff's timeline, are you looking to discuss Gen 2 Navigation Center with our whole council at a particular point?
I would leave that up to the committee to instruct staff. I do think it would be appropriate to discuss the emergency declaration before we do spend more time investigating different options, but if there are no limitations set today by the committee as far as what different options they would like to see or would not like to see, I think we can still get some work done as far as considering different options while we discuss the emergency declaration.
I think just, we've discussed it here now to the point where I would want to hear, I would want a full presentation and hear from the whole council. And if our whole council, if we're not able to, if we can't come to a decision, right, then that's okay too, right? Or if they decline it, that's all right too. But I think I have enough information to move forward to the whole council.
The only thing I would ask of you is just visit with Mr. Conley when he gets reminded what all those reasons were, because they were sufficiently concerning to prevent us heretofore from doing that. So as long as after visiting with him on that, you still want to move forward with it.
Yes,
I'm okay with it.
and I received this idea, right, from communications with Senator Blakespear, but I'm certain there are drawbacks, and I would never want to obscure any of the information. We want to have that all available.
Let's make a list of pros and cons.
That's right. Okay, anything else on the Navigation Center updates discussion? Thank you.
No other updates, thank you.
All righty, well, that will, any more comments, Mayor?
Nope.
All right, that will complete our discussions, and meaning we are adjourned. Thank you.